Love that gavel. Good afternoon, everyone. Thank you for joining us in the Senate Finance Committee. Today is Wednesday, February 28th. We are going to hear 8 bills today. I'm going to quickly read the order. First bill will be Senator Solling and Senator Gazone for the Port of Baltimore renaming. And bill number 2 is Senate Bill 760. Number 3 is Senate Bill 684. Number 4 is Senate Bill 754. Number 5, Senate Bill 595. Number 6, Senate Bill 778. Number 7, Senate Bill 626. And number 8 is Senate Bill 681. Of course, it's all subject to change as our members leave and go to other committees to testify, but we'll try to stick to that order. I do ask, since we have a lot of witnesses today, that we try to keep our testimony to 2 minutes. I will appreciate that. And Senator Solling and Senator Gazone, do you have anyone you want to bring up with you, or should you just do a separate panel?
Governor.
No.
And
Okay, I'll tell you who I have on your panel, but you're
Yes,
going to be short one seat.
yes, ma'am.
Former Governor Robert Ehrlich, former Maryland Congressman Tom McMillan, former Maryland Secretary of the Department of Transportation James Ports, Dave Richardson, if he's here from Southwest, Dave, and Bruce Bariano. So
Yes.
Dave, when someone gets up, you can then sit down. So thank you for being here. So we will begin the hearing on Senate Bill 156, and which senator would like to go first?
I think I'll start,
Yes.
Madam Chair. Thank you. This obviously is about renaming the Port of Baltimore, although it already has been named that for some time. And I didn't know we were going to have a governor here, who I believe did it in an executive order in 2006, I believe. And all this does is we're putting it in the statute. And I think it's the appropriate thing to do. I actually grew up in Baltimore County. I knew the Congresswoman before she was a Congresswoman. As a matter of fact, she even offered me a job. And so I knew her kind of well. And my life probably would have been changed if I had taken that job. You have no idea where I would have risen to. But you'll hear it all through this testimony, I'm sure. She was tenacious. She was driven. She cared deeply about the port and realized the significance of it and the importance of it to the state of Maryland, to the city of Baltimore, and well beyond. So I'm just happy to be here to join with Senator Solling in really codifying this forevermore. That's it.
Thank you.
Thank you, Senator. Senator Solling.
Yes, ma'am. Thank you, Mr. Chairman, and thank you, Chair, Vice Chair, and Committee. For the record, I'm Senator Johnny Ray Solling. The purpose to seek the complication of naming Helen Dutch Bentley Port of Baltimore statue was already expressed. But she was born in 1923 in Ruth, Nevada, and she made history becoming one of the first women to cover waterfront news in the Baltimore Sun. She also was an expert in the Port of Baltimore and led WMAR TV, the port that built the city and state. President Nixon also appointed Helen Bentley the chair of the Federal Marine Commission in 1969. There is so much history we could talk about the good woman and the historian, and I believe she was an icon. And what she did for the port, I don't think anybody else could have. She just didn't make the statement. She made the right moves, and that's why we are here today. And that's why the Port of Baltimore sets records every year, row, and the other things that she has done. Chair and Vice Chair and Committee, I think this is a historic opportunity for you to do something great for a woman that has done great things for the state of Maryland. And I hope that you allow us and you to make history today and approve this bill and make it favorable. And I'm going to thank you for this opportunity. And I'm glad these guests that are here are going to express a lot of support with this. And thank you very much.
Thank you, Senator. Governor Ehrlich, would you like to go next?
Sure, I'll be very brief. I also want to point out First Lady Kendall Ehrlich is here as well. And it's great to be back in General Assembly. It's a little weird, this perspective. Seeing a lot of friends today, and I'm not going to, and I thank the members and the sponsors. And it's really great to be with my good friend, Congressman McMillan as well. I'm not going to go over the resume. Everybody knows it. Reporter for the Sun, the Maritime Commission, and she was certainly an integral part of Team Maryland on the Hill. Very effective in that regard. A friend and ally to many of us, especially Governor William Donald Schaefer. Language that would make sailors blush. A piece of work, one of a kind, broke the mold, tenacious, gruff. But probably the best context I could create here is citing a Politico story upon her passing. There, and I quote from Politico. In 1954, when a dock worker compared her nose to a ski jump, Bentley punched him in the jaw. I'm only surprised it was only the jaw, actually. So all this is the stuff of legend, and I just thought I'd come today, and honorary Senator Biriano invited me as well, and I appreciate that. Just to give you one vignette, one brief story, which really tells it all. Because the fact of it is, as some of you know, we did not get off on a very good start to our relationship. She didn't like me very much. She thought I was going after her seat, which I was, but I was not dumb enough to ever run against her. And so I certainly did not, but we did not start off on a good foot. And then two things occurred. She decided to leave the seat and run for governor, and I dated Kendall Ehrlich. And both of those factors entered into a new phase of our relationship. So I became okay in that regard. And okay led to the following vignette. Once in a while, especially on a Friday evening, I'd get a call. And the call was, Bobby, get over here now. Bring Kendall. And I would take my girlfriend, Kendall Sabisky, with me. And when I arrived at Helen's home, she would have a list of manual labor chores for me to do. Tree stumps, bricks, yard cleanup, and the like, basically manual labor. And I'm not kidding. Kendall would go and I guess drink tea with her or whatever they were doing inside. And I would perform these tasks for however long it took. And then when I finished the manual labor, I would go back in her basement, which was an absolute mess. And she would sit there and tutor me on the Port of Baltimore. She would teach me about the people, the legacy, the issues, the challenges, dredging, the unions, the whole 9 yards. The term master class is overused in this day and age, but it truly was a master class for me, the student, the mentee, and from her, the teacher, the mentor. And I never, ever forgot those lessons. And I took those lessons with me to the Congress of the United States. This is the right thing to do. I appreciate everyone's consideration. She was one of a kind and certainly deserving of this honor. And I thank you very much.
Thank you, Governor. Congressman McMillan.
Thank you, Madam Chair and members of the committee. I had submitted some testimony for the record, so just for that reference, it's a pleasure to be here with my friend Governor Ehrlich and all the other folks who are here to support Helen Bentley. I was elected in 1986. She came in 2 years before me, but because our districts were so close together, I had Northern Anne Arundel as part of my district, and she had Baltimore County, and so we both, in many respects, shared the harbor and the port, and we collaborated. And I can tell you that, as Governor said, she was tough. She was tireless. I remember our delegation meetings. It was always about maritime issues in the Port of Baltimore. I have to remind everybody I had to sit in those meetings so that we could see eye to eye. Same, I might say the same is true with Senator Mikulski. And although we might not have seen eye to eye on all issues, on the Port of Baltimore, we really saw eye to eye. And her one distinguishing, tremendous accomplishment was to get that port dredged to 50 feet, because that made it a world-class port. And as what Governor Moore said last week, we can bring $80 billion of cargo from foreign lands into this harbor. Thank God for Helen. So this is entirely fitting and proper that this legislation codify her name on the port. Thank you.
Thank you. Secretary Ports.
All right, great. Madam Chair, members of the committee, it's great to be with you today. You've heard a lot about Helen already, so I won't repeat, but everybody knows, you've heard it a couple of times, she was tenacious. And she broke glass ceilings way before they were called glass ceilings. When she was at WMAR TV, she would walk right into Hauser's, into the Stag Bar at that time, which is, at that time men only. So to no one's surprise, she walked right in, did her interviews, and I believe she is responsible for why women are now in the locker rooms of sports teams today. She was amazing. And then who could forget her Buy USA or Buy America mentality? She had a station wagon with a tag that said Buy USA. Why? Because she cared deeply about the port and all the men and women who supported the port operations. She was a big fan of labor. And of course, another instance that she had was breaking radios on the Capitol stairs. At that time, Japan was giving our secrets to the Soviet Union. And so she broke radios on the stairs, and she took a congressional trip to Asia Pacific region. And then House Speaker Foley joked with her and said, "Helen, you're the most famous American since Admiral Perry." And then Richard Nixon, you heard Richard Nixon appointed her as to the Maritime Commission. The backstory of that is he was going to appoint her as a member, and she was having none of that. She said, "I'm going to be chair, and that's it." I think he was so scared of her that he actually made her chair of the committee. Governor Ehrlich said she never stopped. You heard it also from Tom McMillan. I remember getting a call 2:30 in the morning. I thought it was a family emergency. It was Helen Bentley. And at that moment, she said, "What are you doing, Jim? You weren't sleeping, were you?" I said, "No, Helen, I was up waiting for the phone to ring." And she said, "Well, good, because you shouldn't have been sleeping if you were anyway." I thought I was having a nightmare. And then she proceeded to talk to me about the port at 2:30 in the morning, because she was on her way back from DC. So that was her time to let everybody know. And I'm gonna thank Governor Ehrlich for dedicating the port to Helen Bentley. I will say this, she was extremely proud at that moment. She didn't know it was coming. It really set her back, but she was also very happy that they named a dedicated crane after her. I was walking with her, and I'm gonna do like Governor Ehrlich did. She said, Jim, you see that crane right there? It's got my name on it. They named that after me." And I said, "Helen, I remember they dedicated that to you." And I said, "Helen, you see all these cranes around here?" She said, "Yeah." I said, "They all have my name on them." And she said, "What are you talking about, Jim?" And I said, "Ports America Chesapeake." She then hit me with her cane. And it was a sign of love when she hit you with a cane. If she didn't hit you with a cane, she didn't like you. But, I'm very proud to be here today. She's an extraordinary woman. She loved the port that built a city and state. And I hope everyone in here gives it a unanimous vote. Thank you very much.
Thank you. And David Richardson?
Yes. Hey, hello, everybody. My name's David Richardson. My day job is with Southwest Airlines, but I'm on the Maryland Port Commission. Been there 9 years. Recently reappointed by Governor Moore. So thank you, Governor Moore, and the Senate for confirming me again. And I work for Helen. I started working for Helen when I was 18 years old. And essentially, I was her body man. And if you're a fan of the TV show Veep, I would be Gary on that show. So I would take the calls, when I'm driving her back from DC at 2 a.m. So the thing with Helen is she had a really heart of gold beyond that tough exterior. And I once, dreaming her driver, you get to talk to her a lot and listen to her phone calls and everything. And she was the real deal in terms of her motivation was both the Port of Baltimore, but also manufacturing jobs in greater Baltimore, whether it be Bethlehem Steel, General Motors, Bendix Radio, I can go on. That and why? I asked her why, why the Port of Baltimore? She, and really down to it, she believed, and as a member of her staff, and we're writing this speech after speech after speech, she was very patriotic, and she really believed the sort of the core, the heart of the American dream are good, high-skilled union jobs. And the type of jobs that you can support a family, healthcare, retirement. And that was really her motivation. So yes, she was a Republican, but I tell you, she viewed everything in two lenses. Were you a friend of the port? Were you a friend of U.S. manufacturing jobs? And were you good for your word? And if you check those boxes, she was your friend, regardless of your political party, gender, race, religion, etc. So just being in close quarters with all that time, I just have to say I loved her very much, very honored to be a mentee of hers and a friend. And then, Madam Chair, one thing, another one of Helen's old friends here, Paul Kelly, and I thought he signed up to testify. He did.
He did, but he wasn't on the sponsor panel, so I hadn't called him.
Oh,
yet,
okay,
but-
okay, okay. We okay. Call him later.
All right.
Okay.
Thank
Thank
you,
you.
David.
Thank you.
Well, actually, I have you. Are there any questions from the committee? I do not see any questions. Thank you all for your
Thank
for your
you.
testimony. I still have Mr. Barriano and Mr. Kelly. Why don't you come up also?
Good afternoon, Madam Chair and members of the Senate Finance Committee. For the record, Bruce Mariano, Anne Arundel County. First of all, I can't thank enough Senator Gazzoni and Senator Stallings for introducing this legislation. And I want to thank you, Madam Chair, and this whole committee for your courtesy, not just in considering this legislation, but I really wanted to make this somewhat of also an additional honor and remembrance of an incredibly great Maryland human being who long before she was a suffragette in her own right. And I say this with the love and respect. You look at your chair and your vice chair. Helen Bentley helped pave those ways that it's just great. I gave each of you a booklet. I hope it's a keepsake. I put this together. We have a art put up in the World Trade Center for her. And this tells you her whole life and her story. There are letters of endorsement and of congressmen and other people that could not be here. But we thank you very much. I loved her very dearly. And without going into it, and I'll end with this, she dramatically impacted my life. And she will always be in my heart, always. Thank you.
Mr. Barriano and then Mr. Kelly.
Yes, I'm not someone special, Congress or anything like that, a big time name. I'm this Johnny Q puppet. But the relationship I had with Mrs. Bentley is just outstanding. I'm a member of the Baltimore Port Alliance, which is all of the individuals or companies that are involved with the merchandise coming into the United States and exporting. And you well know that we don't export much, so there's a lot coming in. And she was a dedicated individual to be sure that everything that was needed for the port to function efficiently, she was there hammering it away. She worked so hard to do that. You can't meet a more dedicated individual than she. She's a Republican diehard. And just for this, I'm a Democrat. But somehow she took me under her wings. When she was at the Port of Baltimore, she would know if I was going to Annapolis, where we have a little session with the people down here, you know, socials. And then she would say, "Are you going?" And I said, "Yes, I'm going." She says, "I'll be outside at 4:30 at the World Trade Center, and you better be there." Bam, there you go. She did things like that. And when we would have customers or people taking up on some of the little ships where you have to climb up the ladder, she was on a cane at that time. And going down, she would be out front, and there's a lot of people there. And she would look back. I would maybe be 5, 6 feet back. For me to come up, get in front of her, she would hand me that cane. And I would get in front so if she fall or something, she could catch me or I could catch her. When we got down to the bottom of it, the way she thanked me, I would give her a cane back. She'd take that cane and slam it right down on my foot. And she would walk away about 5 feet and she'd look back and it's like, "I got you again, Paul." And then, you know, she just did so many things like that. I mean, one of the things she's did beyond that is that she called me up and she said, "President Obama, he's now the president of the United States. You know, I'm not going to his inaugural." I said, "I figured you wouldn't, man." She says, "I got sit-down seats. Would you and your wife like to go?" I said, "You're kidding me." She says, "Do you want to go?" I said, "Yes. I've already taken all of that care of that. Here's where you go pick the tickets up." So I had the opportunity to go to that and the sit-down seats that she had. I'm quite sure there's a ton of other people she could have given that to, but she didn't. But that lady worked so hard for the Port of Baltimore. and it's functioning very well. To me, it's the best port in the whole United States, and I've been involved in it with different committees and functions for the last 35 years here in Baltimore. And the lady definitely needs that port to be named after her, and I hope you all take care of that. If Donald Trump was here today, he would be catching hell from Helen Bentley.
Thank you, Mr. Kelly.
All right.
I don't see any questions and there's no one in opposition. So I appreciate your testimony, and that ends the hearing on Senate Bill 156. Next, we have Senator Kramer, Senate Bill 760.
Madam Chair, I believe there are some people who are signed up, not necessarily as a panel, but may I have them come up to the table? I
Yes.
think you're going to hear a lot of favorable with amendments.
Do you want all of those people up now? So
That would be great. Thank
Karen
you.
Morgan, Kelly Locklear, Stephen Sakamoto Wengel, and Kara Renfro. Thank you.
Okay. All right. And we have one other person for information purposes. If there's something that I guess, Madam Chair, is complex, there are some levels of complexity with the bill. So if we may, thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Ben Kramer here to introduce Senate Bill 760, the Gift Card Scams Prevention Act. Colleagues, I have been looking at a particular aspect of gift card scams for quite a while. This past fall, I decided it was time for me to start formulating how we might address the problem, and I got to work. The particular piece of gift card scam that I was looking at is how gift cards are often utilized to scam people who are either unsuspecting, perhaps they're elderly, and they are told that they need to pay an outstanding utility bill or an outstanding tax bill because the sheriff's on the way, and they're directed to go buy gift cards. And this has been a significant problem and a significant issue, and I'm going to come back and revisit how we are addressing that in this bill. However, I will let you all know, I am a big fan of the Today Show in the mornings. I regularly, that's where my coffee and my dogs pile on and we watch. I'm also a big fan of Vicki Nguyen, who does lots of consumer protection reporting on the Today Show. It was during two of those episodes that aired this past December that I realized there is a significant scam, different than the one I just told you about, called card draining that is being perpetrated, and it is a national problem. And with that, Madam Chair, if I could pause for one moment, we've got a short video teed up, and I'll step out of the way because I believe it explains a lot about the issue so you understand.
I got scammed.
The person scratches the back off and then re-glues the card.
Consumers posting warnings about compromised gift cards, a crime that cost $228 million last year.
The barcode is not there anymore, so you cannot do anything about it.
Police from coast to coast warning about a surge in so-called gift card draining.
We want to let everyone know about the latest scam that we have gotten word of.
Police say scammers steal these cards, then they copy the card number and the security code, then they reseal it. You can't even tell it's been tampered with. When you load money onto that card, the scammer pounces and drains it. It happened to Weekend Today anchor and senior legal correspondent Laura Jarrett. This is a very Grinchy moment with these gift cards. Right? She purchased $2,000 worth of vanilla gift Visa cards at this New York CVS, only to find 3 of her presents to colleagues had scuff marks where the security code should have been, and the funds drained. From the naked eye, these do not appear to be tampered with at all.
Right? Not even a little bit.
Right.
All of the seals look totally fine. In fact, it says on here, if tamper evident, don't purchase. So I checked it before I checked out. Everything looked good from the outside.
Laura showed us one card that appeared to be totally normal, the barcode and security pin untouched. But when we checked the card balance, 0. The money Laura loaded onto the card November 27th disappeared 14 days later. One survey found almost 1 in 4 gift card recipients said they've received a card that was drained. So I went back to that same CVS. Okay, so here's where the gift cards are. They're kind of in the middle of the store, not really under the watchful eye of anyone at the register. So it's sort of easy to see how they could be tampered with. From the outside, they look secure and sealed. I'd like to put $20 on each of these gift cards. We have our gift cards. 8 of the 9 cards appeared normal. Okay, this one has a security code. But then this one has the security code gouged out. Take a look. That has absolutely been tampered with, and we could not see that when it was in the packaging. In statements to NBC News, the Retail Gift Card Association and Vanilla Gift say in part, criminals have come up with more innovative ways to card drain, and they are working to stay ahead of it. They urge the public to report any fraud to police and call the number on the back of the card. CVS adds they're investigating our findings and say they warn customers about fraud risks and urge employees to check gift card racks for tampered cards every day.
I had seen your segment, so I was on notice. I knew that this was going to be an issue. I just didn't think that was going to happen to me.
To avoid a scam, some police say don't buy a physical gift card because it's nearly impossible to know which ones have been compromised. If you do, choose one that's closer to the register or, better yet, behind the counter. Recipients should check the balance and spend their gift cards quickly to reduce risk, and buy with a credit card to increase your chances of getting a refund. And that, luckily for Laura, she did buy with a credit card. She got her money back. The company is now investigating. Just remember, if you suspect fraud, you want to file that report right away with the police and your credit card company, and hopefully they'll make you whole again.
This is crazy because she looked so closely. Yeah. She knew what to look for. She watches Vicky win all the time. And it still happened to her.
It still happened. And let me just show you. This is what it looked like when we bought the card. Could you tell that anything was wrong with that?
Laura's card?
It's absolutely perfect.
Wrong?
This is one of Laura's cards. It looked identical to the one.
Wrong?
You don't.
Oh, you don't.
You just can't.
Wow.
That's how good they are.
So what about electronic gift cards? Is that a better bet?
That is a great question. So in theory, they are safer because you're buying them directly from the website, a legitimate website, first of all, and you're emailing them to the recipient. But you want to make sure it doesn't go to spam or the recipient doesn't delete it. And the other thing is they have to make sure they're checking the balance on a reputable website. Otherwise, scammers have set up these sophisticated sites saying it's a check your balance site. You enter the information, they drain the card that way.
You called me after this happened, and I said to you, because I give a lot of gift cards. I just wrote checks this year.
Good. I'm glad you did.
Just wrote checks.
Craig was like, this was my big
Seriously,
weekend.
every year
I'm not going to do it.
But you make a good point, too. Like, you walk in the CVS, and half the store's behind the plastic anyway.
Why don't they put it behind the plastic?
That may be the next move, putting it behind the counter.
Wow. All right. Thank you, Vicky. Thank you.
Mr. Roker's got something to say.
No, I love Craig actually acts older than I am.
It's true.
This whole thing, why don't they put it behind the thing?
Why don't they?
Thank you very much. Colleagues, gift cards. Every one of us knows when we get one of these, it puts a smile on our face. This is the go-to for so many of our residents when they're looking to just quickly give a gift to someone or they don't have a clue what their interests are. Gift cards. Gift cards should put a smile on our faces, and that smile should stay on our faces when we go to use the gift card in the store that is either of our choice or that the card is designated for. The issue is the packaging of the gift cards is completely inconsistent. Some cards are completely exposed and stuck to the cardboard hanger with nothing more, and you've seen it, I'm sure, utilized a lot. This little ball of glue that just gets stuck as a tab on it, and that's how it's displayed in the store. What is happening? Scammers in mass are walking into the stores, scooping up the cards, taking them out of the store. They then, and some of this packaging, like the ones I just described, or this packaging right here, are exceedingly vulnerable. And they just use a little bit of steam to open the package. They get the card, they get the numbers they need, and they just slide the card right back into the package. The moment, and then they take them, they take them back to a different store, stick them on the racks. So then when you walk in and think you're just picking a gift card up off the rack, you go to activate it, you put however much money the card is either designated for or that you choose to put on the card. It could be $500. The scammers now know you've loaded $500 on that card. They immediately drain it. And that's how just last year alone, over $200 million were stolen from consumers across the country. Interestingly enough, in the segment you just watched, Vicki Gwynn mentioned how the credit card company had covered Laura's loss. Well, it turns out they reversed that and they did not cover the loss. And so, as is the case with so many consumers, that money was gone. And it is appropriate for us as legislators to now take action when we see a huge consumer problem that needs to be addressed. And I will go through the bill with you quickly, but let me share with you. I want to thank very much Kaylee Locklear for helping organize the panel you see before you that are the representatives of the gift card industry across the country. I reached out to Kaylee when I saw what was going on, and I said, Kaylee, there's a problem. I sent her a link to this story, and she started looking into it, and she got back to me. She goes, oh, wow, this is a problem, and yes, it needs to be addressed. With her assistance, we've got the big players in the gift card industry sitting here today, and we have worked through the bill, and you should all have on your laptops a copy of the amendments that have been prepared for the bill and an interlineated copy so you can see how it now reads with those amendments. And I was very pleased that the industry came to the table, and instead of saying, no, we're going to fight you on this, they came to the table and they said, help us to make it work for our industry and the way we do this, and we are going to help you get to your goal, because they acknowledged there is a significant problem and they understand the need for making corrections. Now, gift card packaging comes in all kinds of shapes and sizes, and I want you to see that in some instances, there's a tab that's on the back of the packaging that protects numbers that are otherwise exposed by other companies in their packaging. And then there are packages that actually require the consumer physically tear open this strip on the back, and in doing so, makes it clearly evident that the package has been tampered with. This package can't be steamed open and resealed. So the bill before you puts into place standards for the following. Within the retail setting, our retailers will provide at the gift card sales location signage. And this is great. This was a Safeway food store I went into, and they've already got up a clear notice that says, have you been asked to buy gift cards to pay a fine, taxes, fees, or to help someone? And then it says, stop, you may be a scam victim. The bottom line is, gift cards are for gifts, not for paying debts. So wherever gift cards are sold, at the rounders, at the displays, there would be this cautionary notice. Furthermore, those employees who work in the businesses that sell gift cards will be required to receive training to look out for scams, so that if somebody's coming in and suddenly grabbing $1,000 worth of gift cards, there will be a question, or grab a manager and say, hey, wait a minute, why are you buying all these gift cards? And ask the simple question, is this to be given as gifts, or are you buying them to pay a debt? Because once again, that's how the scammers roll. Once they get those gift cards or the information on it from the victim, that money's gone, and there's no way to trace who it was that caused the victimization. The bill further provides that gift card manufacturers going forward will now be required not to simply put a gift card on a piece of cardboard with a little tab of glue, but they will actually have to ensure the gift card is securely enclosed in a way that clearly will show evidence of tampering. So none of this, we can steam it open and then close it back up. Nobody will know the difference. The package will have to show clearly evidence that the card has been tampered with, and the card will be required to provide a notice on it that if the card shows signs of tampering, don't buy it, don't sell it. Warning to both the cashier as well as the purchaser. Finally, the bill also establishes some rules of the road for resellers of gift cards, a source of scamming, because scammers will get the cards, sell them to these resellers who then put them typically online. I don't believe at the moment anyway, it's done at a retail level, but put them online to be sold. And the industry has coalesced around how important those standards are that are in the bill for securing these resellers and minimizing the opportunity that they will be part of the process of victimizing consumers. And that is the gist of the bill before you. Once again, I'm pleased that we worked through this with the industry, with the retailers, and I believe the bill before you will be a national model for all other states. And in fact, we'll finally be ahead of California in doing something. And and the rest of the world globally will also be able to look at what we here in Maryland are doing to set the standard for protecting our Maryland residents from this plague of consumer fraud surrounding gift cards. With that, thank you, Madam Chair, and I'll turn it over to the panel.
Kelly, would you like to start?
Okay. I'm glad to. Madam Chair, honorable members of the committee, for the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance. We are here favorable with amendments. Thank you so much to the sponsor, to the industry retailers. This has been hours and hours and hours of negotiations, hence the 13 pages of amendments that you see before you. And to be really clear too, this will change gift cards nationally, not just here in Maryland. So these security protocols and standards that we're putting into place here will be applied across the country. There are over 1.5 billion gift cards that are sold here in the United States. So I just wanted to throw that out there. Essentially, the amendments before you and the senator touched on them cover quite a few areas, but this online third-party registration and record keeping is essential. We do know that scammers are going online and they are selling these gift cards there. I mean, that makes sense. So they will have to keep records for a period of 3 years. Georgia has had this law on the books for a couple of years. It works there. Industry sat at the table. We know that we can comply with that. Retail employee training, we are fine with that. New Jersey has a law around training, and that's what we'll be mimicking there. New York has a law around signage. So this is where we already do this in the state of New York. So we are fine going ahead and posting signs at either point of sale or where gift cards are sold. So we're good there. Sell-through dates were critical. And worked with industry on this. There is a differentiation here you'll hear about between open loop and closed loop. We can get into that, but there are different sell-through for us to protect industry and retail. There are exemptions in here for small mom and pops. We represent the main streets in the state, so we had to think about our main streets too and how this would be applied to them. I'm glad to answer questions around that. And then finally, we work through penalties too. So I'm glad to answer any questions the committee has. We urge the adoption of the amendments and a favorable report. Thank you.
That was perfect, Kelly. Thank you. Stephen, would you like to go next?
Thank you. Good afternoon, Madam Chair, members of the committee. Steve Sakamoto Wengel here on behalf of the Consumer Protection Division of the Attorney General's Office. I'm here in support of Senate Bill 760 with one amendment. Senator Kramer eloquently described the issue here. We do believe that this bill would go a long way to addressing, the scams that he described, as well as the gift card draining that the video showed. Embarrassingly, a good friend of mine was a victim of one of these scams. She had called saying that she needed to pay her taxes right away, or else the police were coming to take her away, and she went and bought gift cards and read them the numbers for the gift cards, and it's like, you do know where I work, don't you? And unfortunately, she didn't get that money back. The one amendment that we have is we do not believe we should be registering every merchant who sells gift cards online or online gift cards. There are likely thousands, if not tens of thousands of merchants in the state that do that. And we would be doing nothing but, I understand that Senator Kramer has agreed to remove that requirement from the bill. So with that, removed from the bill, we would urge a favorable report. Thank you.
I can go next.
I think that one might be.
Yeah, pull it all the way over here. There you go.
Got it.
There you go.
Hi, I'm Kara Renfro. I'm the Senior Vice President of Global Operations at Blackhawk Network. Blackhawk is a branded payments company, so we enable the distribution of brands into third-party retail distribution channels. So we feel like we're uniquely positioned to participate in and support this bill. We're connected with all of those brands. We're connected with all of the retailers. We are currently spearheading and leading an industry coalition in partnership with federal law enforcement, Homeland Security specifically, to proactively understand, disrupt, and dismantle schemes that are impacting the gift card industry. And our immediate focus is on this physical gift card draining. So we have a lot of data and information around this. And Blackhawk has actually been working on our packaging for our own products and with key partners on their products for many years now. So we are very much in support of this bill and protecting consumers, protecting our industry, and we're looking forward to supporting the industry in implementing the requirements that we've outlined in the bill. We've worked together with the senator and with the teams on amendments that we feel are doable and appropriate. And you have our full support. Thank you.
Thank you, Kara. And Karen Morgan?
Yes. Thank you, Chairman Biden, all members of the Senate Finance Committee. For the record, my name is Karen Morgan. I'm a member of the Executive Council for AARP Maryland. We're here in support of Senate Bill 760. As Senator Kramer mentioned, over $200 million in gift card fraud happened as reported to the FTC in calendar 2023. But make no mistake, the vast majority of gift card fraud goes unreported. So the monetary losses are likely significantly higher. Buying online is not a panacea. I myself had a gift card drained of most of the value, and I hadn't done anything with the gift card at all, but I guess I didn't spend it fast enough because the scammers got to it before I did. I had a family member who was victimized by a grandparent scam, and she was told to buy gift cards, and she was on fight or flight, must rescue, and so she bought gift cards. Fortunately, we were able to intervene before she lost a huge amount of money, but $1 is too much. In a recent survey that AARP did of relating to fraud, 9 in 10 consumers agreed, and 61% strongly agreed that lawmakers need to do more about fraud. And that includes gift card fraud. We should be safe when we're buying gift cards. We should be able to go into a store and buy a gift card. And we shouldn't have to worry about how much packaging there is or what it says or whether it was steamed. And have to go through all that, it's just exhausting. We need to address the problem, which is fraud. And we also need to get the message out that gift cards are for gifts. That is AARP's mantra. We say it in every presentation we do about fraud. Gift cards are for gifts. If you're buying them for something else, that's a problem. And we have stories of people who were in the process of buying gift cards and they remembered an AARP video or they saw a sign in the store and it caused them to stop and maybe not buy the gift card. So with that, we support Senate Bill 716. We encourage a favorable report. Thank you.
Thank you. Do I have any questions for the sponsor or this panel?
That's how good this bill is,
Yeah, that's how
Madam
good it
Chair.
is.
Look at that.
So your last person was just to answer questions, correct?
Yes, ma'am. Thank you.
I didn't have him listed. Senator Ellis?
Almost got out of here.
Almost got it. You're good, but not that. No, you are good. So I think someone said the mom and pop locations will be exempted.
Kind of.
So will that make them the place for the scamsters to go?
I
I'm
would
not sure.
be happy to address that. So there are circumstances where we have, for instance, small grocery chains here in the state, 2 or 3 stores. They are being provided an alternative because they're small. If they prefer not complying with the secure packaging requirements of the bill, under the bill, they will be required to secure the cards themselves.
Okay.
So we're giving them an alternative. If they don't want to participate in the packaging standards, then they will be required to secure them within their business, and only an employee of the business is permitted to have access.
Sounds right. Thank you, Senator.
Yeah.
Thank you.
Thank you.
Thank you, Senator Ellis. Any other questions for this panel? Oh, Senator Mounts.
Thanks, Madam Chair. Just a quick question. Is there any fee or cost associated with the requirements in the bill with any of the retail establishments, any of the businesses?
Is there any fee for the retailers? No. No,
Thank you.
nothing at all.
That ends the hearing on Senate Bill
Thank
760.
you, Madam
Thank you
Chair.
very
Thank you,
much.
committee.
And next, we're going to go out of order because we have a senator in a different committee. So Senator Helen, I think I saw you come in.
Yeah.
Would you like to bring up your panel?
Yes, please, Madam Chair. I believe we have a couple of other folks. We have one virtual, and if somebody is here, I don't know if I see her, Pegeen Thompson from the Maryland Hospital Association.
I don't have her listed.
You don't have her listed?
Jake Whitaker's here.
Jake Whitaker?
I have Jake, I have Dr. Courtney Henry, Dr. Farah Tavakali, and you.
Okay, if Jake
And
is,
then your virtual person.
okay. All right, I don't know if Jake is here, but
Time of year, he's probably in another committee testifying.
could be, could be. All right, good afternoon, members of the Finance Committee, Madam Chair and Madam Vice Chair, who's over in my committee. My name is Shelley Hedelman. I'm a senator from District 11 in Baltimore County, and I'm pleased to be here today to present Senate Bill 754. This is a bill about a practice called white bagging. And this is when payers require that patients get their medications from a specific pharmacy. These medications are high-cost specialty medicines for treatments like cancer and autoimmune deficiencies that require administration by a healthcare provider. To be clear, these are not medicines that a patient can take on their own. As it now stands, payers have the ability to steer prescriptions to certain pharmacies via a third-party services to where the patient would receive them. And I would say, and you'll hear too many times, patients could get the medication in a much more efficient and effective and direct manner. This bill would restrict payers, namely private insurers, from unilaterally mandating that clinician-administered drugs be sourced from an external pharmacy. To be clear, it doesn't outlaw white bagging as a practice. The bill's intent is for providers and payers to mutually agree on instances in which white bagging contributes to lower costs and better outcomes, and it restricts payers from unilaterally mandating the practice for certain drugs. White bagging often exists when payers restrict their coverage of certain drugs to a narrow network of pharmacists, which can cause delays in care when drugs are harder to procure. According to the American Hospital Association, white bagging can contribute to safety systems being bypassed, the fragmentation of medical records, and issues with supply chains, which can contribute to drug waste. Several boards and societies of pharmacists, and some of which are submitted as written testimony, have identified issues with payer-mandated white bagging. A study in the Journal of American Medicine found that white bagging can increase patient out-of-pocket costs by $180 per month. For some drugs, it can be a fundamentally inefficient delivery of services that could otherwise be delivered in hospitals for whom drug rates are regulated. This creates less competition with a smaller group of pharmacies, reducing patients' prompt access to care and fracturing the care delivery service. Furthermore, there's no evidence supporting the claim that restricting white bagging increases premiums for patients. Ultimately, the spirit of this bill encourages providers and payers to come together to mutually agree upon the delivery mechanism of drugs that best provides for patients and lowers costs, instead of payers restricting their coverage to a short list of specialty pharmacies with whom they have special agreements. We'll have a variety of perspectives to show here on my panel, and I urge a favorable report for Senate Bill 754. Thank you so much.
Thank you, Senator. Who would like to go next? Thank you.
Good afternoon, Madam Chair and committee members. My name is Farah Tavakoli, and I am a clinical pharmacist. I work at the University of Maryland Medical System, and I am the chair of the Legislative Affairs Committee for the Maryland Society of Health System Pharmacists. I have lived in Maryland my whole life, and I'm excited to be here today to support Bill SB 754 to contribute to improved healthcare access for residents of my home state. This bill prohibits payer-mandated white bagging in all care settings. To further explain white bagging, I want to start with an analogy. Imagine you have a dining plan and you plan a nice evening out at a restaurant. Instead of ordering off the menu and having the chef use their own ingredients, your dining plan requires a specific grocery store to deliver your steak, potatoes, wine to the restaurant and ask the chef to prepare your meal using this food from the outside. That is absolutely absurd, and we would never ask a restaurant to do that, nor would a restaurant agree to do that due to several health and safety issues. And that is exactly what white bagging is. It is when payers require patients to get their medications from a specific payer-mandated pharmacy and then deliver that medication to the clinic or hospital where the medication is to be administered to the patient. What I want to point out here is that the hospitals and clinics already have these medications in stock where they can safely administer it to the patient. I also want to call your attention to SB 526, which is similar to the bill that we are proposing today. I am happy to see that other senators and delegates are focusing on the issue of white bagging. However, unfortunately, this bill, SB 526, is incomplete compared to the bill that we are proposing today because it only prohibits white bagging in one care setting, physician clinics, which falls short of the objective to protect patients. Barriers to patient access is no less of an issue in hospitals than it is in any other care setting. With that, I urge a favorable report of SB 754 and happy to take any questions. Thank you.
Thank you. Who's next?
Good afternoon, Madam Chair, Madam Vice Chair, and the Finance Committee members. My name is Courtney Henry, and I'm a medication safety pharmacist. I practice at MedStar Montgomery Medical Center, and I'm here to share my support of Senate Bill 754 as a representative of the Maryland Society of Health System Pharmacists. Payer-mandated white bagging is a patient safety and quality issue, and I urge the leaders before me to support this bill. The first time that I encountered white bagging, I did not even know the term. Usually when we purchase medications in our hospital, it's a well-oiled machine. We know our buyer, we know our delivery service, and everything comes in when it's supposed to. But on this particular day, my pharmacy buyer was in a complete panic. They had a patient waiting on a medication that had been promised to be delivered that morning, but the medication wasn't there. The contact person that they had didn't have tracking information for the package, and we had to figure out who to even contact in the first place. I stepped in to assist them, and after calling multiple people, I ended up having to resort to Googling a pharmacy, hoping that I could find information for this. Finally, after getting transferred several times, I found someone who could help me and was able to get tracking information for a third-party delivery service. That medication was located at a site that had machinery downtime and had no chance of making it to the patient that day. In fact, it was so delayed that we had to start the process completely over because the medication was no longer usable due to the long duration in transit. We had to tell the patient their medication was delayed. And in that moment, I'm just thinking of how much time we've spent on it, how much time the patient has sat there waiting for this medication, and what an inconvenience it was for them to be there this whole time. And then the patient said he wasn't sure if he wanted to even come back. And that's what it's like to be a patient, to have your health system fail you again and again, and to lose your only option for survival. And that's the reason why I'm here today and urging you to support Senate Bill 754 to ensure that white bagging will no longer continue to allow for shipping delays, lost drugs, and ultimately delays in care. Thank you.
Thank you. Jake, would you like to go next?
Great. Thank you, Madam Chair, Madam Vice Chair, members of the committee. I'm Jake Whitaker on behalf of the Maryland Hospital Association, here to testify in support of Senate Bill 754. MHA is supporting Senate Bill 754 to protect patient safety and improve access to prescription drugs. This bill prohibits certain insurer and PBM practices commonly referred to as white bagging. Under white bagging, payers will restrict where and how these patients receive their medications. White bagging does not apply to all drugs, but often involve high-cost drugs that need to be administered by a clinician, such as cancer drugs. Instead of allowing hospitals to dispense drugs already available on site from its own inventory to a patient, white bagging requires patients to wait while a payer-selected specialty pharmacy ships the same drugs to a payer-approved site for administration. If there are shipment delays such as a storm and FedEx can't deliver them on time, then the patient suffers because they can't receive the drug when they need it. Also, if a patient's condition were to change, drugs sometimes have to be adjusted. So for example, increasing or reducing the dosage on the scheduled day of administration. If a hospital can use its own inventory, they can make those modifications the same day rather than waiting for the new drugs to be shipped to the patient in a place where and at a time where they may not need it. At best, these delays are an inconvenience, but they also have serious health consequences. So for the aforementioned reasons, we urge the committee to support Senate Bill 754 and help patients receive the drugs from the providers they trust instead of a location chosen by insurance companies. Thank you.
Thank you, Jake. And our last person is virtual Dr. Leah Rossman.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Dr. Leah Rossman, and I am a certified specialty pharmacist and clinical pharmacy specialist. I've spent my entire professional career in Maryland, and I am testifying today in support of legislation that will preserve and improve timely patient access to critical medications. I've worked in the inflammatory bowel disease program at University of Maryland Medical Center for over 4 years, assisting with both medication education and access. Insurance mandated dispensing of clinic administered medications or white bagging, usually through insurer-owned specialty pharmacies, has resulted in delays and lapses in treatment for a significant number of my patients. I would like to share some specific examples of problems we've encountered with white bag mandates. For patient number 1, the subcutaneous instead of the intravenous formulation of medication was delivered to the infusion center, resulting in a delay in therapy. For patient 2 and 3, temperature-controlled packages were delayed in delivery for days, resulting in medication becoming unusable. Medication had to be reordered, resulting in delays in therapy initiation. For patient number 4, medication was lost inside a health center, resulting in the patient receiving a large bill for stock medication. For patient number 5, her refrigerated intravenous medications were shipped to her home instead of the infusion center, leading to compromised cold chain stability. For patient number 6, he was unable to find an infusion center covered by his insurance, willing or able to accept the mandated white bag medication from his insurance. A lengthy appeal process had to be performed, resulting in months-long delay in therapy. These are only a few examples, and similar situations have occurred for dozens of my patients since white bagging mandates have become more common. I often counsel patients that having a chronic disease is like having a part-time job. You need to set aside time to manage your treatment, therapies, and follow-up evaluations. White bag mandates increase the administrative burden on patients while also increasing the risk of errors and opportunities for medications to become compromised. As both a compassionate clinician and as a multiple sclerosis patient who relies on office-infused specialty medication, I urge a favorable vote on SB 754, which will improve healthcare equality, improve economic competition among infusion providers, and ease the already heavy burden on chronically ill Marylanders. Thank you.
Thank you, Dr. Rossman. I have a question. Senator, who are you directing your question to? Senator Reed.
I actually know who this time. I have to be sure I know that all the time. I think I'm going to ask a question of Dr. Is it Tavakoli? So all of your testimony is very helpful and interesting. You talked about some specific cases of problems that both of you did actually. This is really kind of the first time I've heard about white bagging in a broader context. Why does white bagging happen? What are the opponents of this bill going to say? Like, why is it? I'm sure there's a decent enough reason for why you would have white bagging sometime. Can you explain? Can you just give me some context? That's what I guess I'm asking for, some better context. So why does it happen? Why does it happen? And then should it be outlawed? Why should it be outlawed completely, I guess?
Yeah, sure. Thank you for your question, Senator. First of all, I want to bring up that white bagging has become much more common in these past couple of years, which is why it is such an issue today. Since 2021, 32 states have introduced legislation to restrict or prohibit payer-mandated white bagging practices, and at least 12 states have enacted laws to curtail payer-mandated white bagging. So this is an issue across the United States. Because it has become more common, the reason it's becoming more common is because payers, they are incentivized to to move forward with white bagging because they have control over where patients are getting medications. They are receiving kickbacks for patients going to specific payer mandated pharmacies. And having that control is, what they want. It's in their benefit to have it. But what really we need to be focusing on is patient safety and medication safety and patient access to care. By prohibiting payer mandated white bagging, we're improving medication safety because we know where the medication is coming from. We know it's coming from a trusted source, and we're not having to wait for the medication to be delivered to the patient where it could be at the wrong time or the wrong dose.
Has it always been an untrusted source, or is this in your view and your experience and research, or was there maybe a proper role for it and it's just gone too far?
If it's all right, I'll step in for this question. This has become a more common practice recently, one, because we're using more specialty drugs. This has exploded even in the past decade. So more patients are, able to utilize more of these medications. What our bill that we're bringing today, it doesn't outlaw it because there will be circumstances where it may be such a rare medication that it's not on the formulary, and we don't want to prevent patients from getting access to care. But when a patient shows up in the clinic and their liver enzymes are elevated, and I have that medication right next to me, I should be able to use that for this patient.
And I'm not trying to interrupt you, but I know we won't want to go too long. So basically what's happening is your testimony is that insurance companies are saying you can't fill it.
Correct.
Because our deal is.
Correct. And this also
is to fill these kind of drugs a different way.
PBMs do make money from billing for drugs.
I'm aware.
So this also changes how billing is done in general. It moves from a pharmacy benefit to a medical benefit when medications are given in the hospital using medications provided.
Thank you. I think my concern would be, I'm sure there's an argument that there's some cost savings with this. So I think we have to look at that balance, but I do appreciate your answers because it's an interesting issue. Thank you very much. Thank you, Madam Chair.
And there is no evidence or data to support that there is cost savings with white bagging. There is actually the opposite, and it is published in the Journal of the American Medical Association that white bagging leads to increased cost.
Thank you. There are no further questions. I know. We're trying. We have like 75 people to testify today. So that's why I asked people to try to stay to their 2 minutes and ask my senators to ask one person a question, because if everybody answers a question, we'll be here till midnight. So thank you very much for that consideration. That ends this panel. Thank you very much for your testimony. We have 6 people unfavorable. Matthew Celentano, Heather Cascone, Michael Johansson, Camille Fesh, Tricia Swanson, and Kimberly Robinson. So Matt, would you like to start, please?
Sure, Madam Chair.
And then
Thank
we'll
you
just
very
go right down the line.
All right.
Thank you.
Madam Chair, thank you for the opportunity. Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP opposed to Senate Bill 754. Carriers use lower cost specialty pharmacies because they save money for patients and help make premiums more affordable. That's the most simplest way to explain this bill. Specialty pharmacies can deliver drugs directly to the physician's office or to a patient's home right before the patient's appointment. I have personal experience on this front. This means that patients can avoid inflated fees and other costs that hospitals and physicians charge to buy and store specialty medications themselves. For example, specialty pharmacies can protect patients from hospital markups for prescribed drugs, which on average run 200 to 400% of the hospital's their acquisition cost. Specialty pharmacies are used for prescription drugs that may be safely delivered in this way. These lower cost pharmacies are subject to the same supply chain safety requirements that any other dispensing pharmacy under federal laws and state laws and regulation. Specialty pharmacies must also meet extra safety requirements for specialty drugs that are imposed by the FDA and by drug manufacturers. They also satisfy stringent state and federal requirements for the safe storage, handling, and dispensing of the drugs. The majority of specialty pharmacies also employ clinical specialists that are available 24/7 to provide additional support to patients. In some of these cases, the clinical specialists directly administer the medications to patients. This bill will completely upend that. I won't belabor the point because I know you have a long day. I provided extensive written testimony, but we asked for an unfavorable report on Senate Bill 754. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee, Tricia Swanson on behalf of Care First. I won't repeat what my colleague said about specialty pharmacy. I will just add a little fact and anecdote from the Care First perspective. Specialty pharmacies are critical for us in our efforts to keep prescription drug costs down. As you've heard me say, I'm going to try and say it a couple more times, but healthcare dollar, looking at the healthcare dollar, pharmacy is 35%. And when we're looking at our specialty pharmacy network, it impacts 3.8% of our members. They're the ones accessing those specialty drugs. Those 3.8% of our members, they account for 54% of our total drug spend. So this is a huge problem in terms of cost. And so the ability that we have to have an exclusive specialty pharmacy network is critical for us to keep those costs down. And with that, I will respectfully urge an unfavorable report.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of the Cigna Group, respectfully here in opposition to the bill. I'll do my best to not overly repeat things you've already heard from Mr. Celentano and from Ms. Swanson. But cost is certainly a factor, but patient safety is an important part of this for us as well. When we look at how we administer our white bagging program, there are lots of things that we think are important safety features that are part of that really do go to some of the things that you heard from the proponent panel. Things such as making sure that there are in fact tracking details, signature upon receipt, exception policies in place, because sometimes someone's need does change. If we were going to still cover that medication and not charge that patient a second time for that medication, they're only going to pay for what they actually ended up needing when that service is being rendered. Ensuring that there's access to a pharmacist or a nurse who can answer questions about what's happening with that drug 365 days a year, 24/7. All of these things are part of what we do to make sure that this process is safe. And at the end of the day, what is most important is that patient is getting that drug. But when it comes to also why cost is part of this conversation on our side, there is in fact a tremendous amount of evidence about what the cost of prohibiting white bagging looks like. And interestingly enough, in Senate Bill 526 that was referenced, Senator Lamb's bill that we heard the other day, which does do this in a limited, focused way, he himself actually testified to some of those studies that talk about the cost that this could provide. So I'm just going to give you a couple of numbers. For example, an April 2022 report in the Journal of the American Medical Association revealed that the National Cancer Institute designated cancer hospitals mark up the top 25 cancer therapies anywhere from 120% to 630% from their estimated acquisition costs. A 2021 analysis of hospital price transparency disclosed requirements under federal law found that hospitals mark up drug prices by 250% on average. There are specific examples in that study of drugs that were marked up. And a 2018 report by the Moran Company for Pharma found that on average, hospitals charge 479% of their costs in administering those drugs nationwide. And so for these reasons, we urge an unfavorable report.
Thank you. Madam Chair, members of the committee, my name is Heather Cascone and I represent America's Pharmacy Benefit Managers through their trade association, PCMA. I am here to make three main points to you today. The first is around the safety and security of specialty pharmacy dispensing. Specialty pharmacies use shipping protocols based on the U.S. Pharmacopeia standards, much like any physician-administered office or hospital would. They ensure the drug's integrity, including temperature-controlled packaging, specialized shipping containers, and finding the most safe and most direct package journey, even taking into account weather along the route. Secondly, they use the same shipping carriers that any other hospital or physician-administered site would. We're talking about the Postal Service, FedEx, UPS. Secondly, specialty pharmacies are more affordable than the physician buy and bill system. They evolved in part because of the practice of buy and bill, which grew to be really increasingly more costly. Instead, specialty pharmacies buy in bulk, just like you would at a Costco buying paper towels, and you avoid the additional markups from the provider, ultimately passing that savings to patients and to plan sponsors. My last point is around statistics and research. There was some called into some question whether there was facts supporting our point of view. There are approximately 80 drugs administered in this way through a white bagging model out of the more than 20,000 drugs that exist in the country. And they are projected to cost the system $230 billion in 2023. Several studies outlined in my written testimony cite dramatic cost markups in physician offices and hospitals. Most notably, the Massachusetts Health Policy Commission did this analysis and reported this research. In the absence of any kind of provider commitment to limit these costs, we must urge an unfavorable report. I appreciate your time.
Thank you very much, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Camille Fesh here on behalf of PCMA, Heather Cascone. After this talented panel, it's very hard to come up with something that isn't merely repeating what they say, but just want to drive home a couple of quick points. PBMs, pharmaceutical benefit managers, are third-party administrators that are contracted by the health insurance plan. Their goal, as Heather and the rest of the panel have mentioned, is to be concerned about cost, and particularly cost of the specialty drugs. The cost is continually increasing significantly every single year, and it does affect our ability to provide healthcare to all the rest of the lives covered under health insurance plans. To patient safety, as has been over, there's a number of protocols and procedures within PBMs, within specialty pharmacies that ensure the safety and accuracy of these prescriptions. And it was mentioned that before that this is a shift from the pharmaceutical benefit to the medical benefit. And doing that, it does allow the hospital or the other entity to not keep itself restricted to the cost to what the PBMs would be. The PBMs agree to reimburse for the medication. It does have a significant cost, which does impact patient safety. It impacts costs, and it impacts the ability to deliver care. For all of this, we urge an unfavorable report. Thank you.
Thank you. Do I have any questions for this panel? Of course, Senator Reedy.
To one person.
There you go.
I think I'll ask Heather if that's okay. Heather. I know of course, you're going to spend some time here today with us talking about PBMs. I do have a question I do understand there's a role in cost savings, and I appreciate that. Is there somewhere where maybe there's a need for there to be a little more flexibility for these specialty drugs when there's more of an emergency situation, or maybe emergency is the wrong word, but just situations where the drug is needed and getting it from a specialty pharmacy is going to take several hours, which then bleeds into another day, or you can think of an infinite number of anecdotes. But I mean, can you talk? Is there a way for us to get a little bit more flexible with that? Because I understand the point about the markups at the hospital, but I also think there's situations where that's probably not the case. I mean, can you just speak to that?
Sure. I can answer that question, but probably some of the health benefit plan sponsors can answer that question as well. But there are, of course, exception policies for emergent basis cases when there are instances where there's an urgent matter that needs to be addressed. There's always an exception policy that exists. PBMs will, of course, execute on whatever the plan sponsor directs us in that way.
Can it be, but once somebody's agreed to a plan, are they locked in like for the next year, or is there a way for them to say, hey, our members are running it? I'm just trying to understand if there's a way to be flexible within a contract.
Yeah, I mean, those exceptions and exemptions exist within the plan contract already.
Okay.
It's not like it would need to be created separately outside of the plan design. It already exists.
Okay. Thank you, Madam Chair.
Senator, do you have any other questions for this panel? Thank you very much. I think that ends the hearing on Senate Bill 574. No, I'm sorry, 754. Senator Hershey, I think we're going to bring you up next. I don't see Senator Augustine. So. Senator Hershey has a panel of Megan Warench, Melissa Hurt, and Matt Prentice.
Thank you, very much, Madam Chair, members of the committee. For the record, Senator Steve Hershey to present Senate Bill 595, This committee has worked tirelessly to help patients drive down the cost of prescription drugs. While some bills may have been more complicated because of the interrelationship between manufacturers, insurance carriers, and PBMs, this bill is quite simple and will directly reduce the patient's out-of-pocket expenses. As a background, to help patients better afford and stay adherent to their medicine, many third-party entities, including pharmaceutical manufacturers, nonprofits, and charities, offer cost-sharing assistance. Senate Bill 595 ensures that copay assistance counts towards a patient's deductible. That's it. No matter what the carriers or PBMs tell you, it's that simple. But why is it necessary? Well, because unfortunately, insurance carriers and PBMs are increasingly adopting policies often referred to as accumulator adjustment programs that block manufacturer cost-sharing assistance from counting towards patient cost-sharing requirements. Many patients who have benefited from cost-sharing assistance to afford their medicines have no idea that their health insurers and PBMs are no longer counting cost-sharing assistance towards their annual out-of-pocket limits. As a result, patients may face thousands of dollars in surprise out-of-pocket costs for their prescription medicines because manufacturers' cost-sharing assistance is not counting as if it was paid by the patients themselves. That's why the PBMs are here in opposition. They're currently double dipping. They're getting paid both through insurance, through copay assistance, and by the patients. So contrary to their opposition, this does not increase premiums. This doesn't incentivize physicians to prescribe higher cost drugs. It simply says that cost-sharing assistance must count towards a patient's deductible, which would eventually save patients out-of-pocket expenses. This bill will bring Maryland in line with 19 other states that have passed similar legislation, including our neighboring states of Virginia, West Virginia, Delaware, and Washington, D.C. Madam Chair, I've got an extremely informative panel that will talk about the specifics on how this legislation will work and also how copay assistance has made a positive difference in their lives. With that, Madam Chair, I would ask for a favorable report.
Thank you, Senator. Megan, would you like to go next?
Can Matt go?
Whatever order you want.
Thank you.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Matt Prentice, and I'm the Director of State Policy with the Immune Deficiency Foundation, headquartered in Hanover, Maryland. On behalf of the Maryland All Copays Count Coalition, we strongly support Senate Bill 595. Our coalition represents Marylanders living with chronic and rare conditions who rely on specialty drugs. To offset high out-of-pocket costs, patients will apply for and receive copay assistance. In recent years, health insurers and PBMs have begun implementing new programs that prevent any copay assistance funds from counting towards patients' deductibles and out-of-pocket maximums. These programs eliminate any benefit from copay assistance and result in insurers and PBMs receiving both the assistance and the patient's full out-of-pocket costs. Health insurers and PBMs will say that these programs help reduce healthcare costs by making patients try cheaper alternatives. However, as we have submitted for this hearing, studies show that specialty medications where copay assistance was used represents only 3% of claims for a product that may have a generic alternative available. You may hear that these programs are in place to reduce costs for all patients and consumers. However, in the 19 states that have banned this practice, there is no evidence to suggest a correlation between banning these programs and an increase in premiums. That means copay assistance doesn't steer patients to costly medications. It doesn't make healthcare costs increase for all consumers. It only provides financial help for patients to access the medications they rely on and that their doctor has concluded is best for them. To date, 19 other states, including neighbors Virginia, West Virginia, and Delaware, the District of Columbia and Puerto Rico have passed legislation to ensure that copay assistance counts. We respectfully request your support for Senate Bill 595 to ensure Marylanders can fully access the lifeline that copay assistance provides. Thank you.
Good afternoon. My name is Megan Warrench, and I live in Owings Mills, Maryland with my husband and my 2 children. My youngest, Cassius, was diagnosed with a severe hemophilia at 20 months. Today, I advocate for the hemophilia community supporting SB 595. Hemophilia, a rare genetic bleeding disorder, poses daily risks, spontaneous bleeding in organs, joints, and muscles if clotting factor medication is not administered. Cassius's diagnosis was unexpected and altered our lives profoundly, leading us into a world of treatment complexities. Treatment advancements like emicizumab, also known as Hemlibra, have improved Cassius's life, but affordability remains a challenge for us. Copay assistance has been vital, as hemophilia treatments are very expensive and lack generic and low-cost alternatives. Navigating insurance complexities became essential for our family, but even with expert advice, surprises like copay assistance accumulators emerged. This year, despite assurances from my employer, our insurance failed to apply our copay assistance to our deductible and out-of-pocket maximum, leaving us with $15,000 due out of pocket. Our situation highlights a troubling trend: insurance double dipping. Our PBM and United Healthcare accepted our copay assistance of $15,000 donated on behalf of my son's care. So my question is why? Why is this not credited to my account? Why am I being held to pay $15,000 from my own pocket on top of money already accepted? While families such as ours struggle to meet costs, insurance companies are profiting at our expense. The PBM even tried to hold shipment of Cassius's medications due to the unexpected outstanding balance. This copay accumulator is putting our family's finances and the health of my son at risk. Over the last month, I have spent almost 100 hours on the phone with specialty pharmacy reimbursement staff, my pharmacy representative, the Hemophilia Treatment Center, United Healthcare, and Hemophilia Foundation chapter staff trying to resolve our situation, trying to determine what my real bill is and understand how and why this practice remains allowed. If I lost my job due to me dedicating my time to this unexpected issue versus meeting my professional obligations, I lose our health insurance. This could result in higher costs to the state, all because of corporate greed. Managing life with a child with a chronic condition can be hard enough, and now we must also fight for fair payment for medications against insurers. SB 595 aims to rectify these injustices, ensuring co-payments contribute to out-of-pocket costs and not to insurance companies' bottom lines.
Megan, will you finish, please?
Yes, ma'am. SB 595 protects families. Please pass 595 out of committee today.
Thank you. Melissa?
Good afternoon. My name is Melissa Hurt, and I'm here today on behalf of the bleeding disorders community. My son Jay was born with severe hemophilia 29 years ago, and I too have moderate hemophilia. We live in Lothian, Maryland, and I am here today to ask you to vote yes to Senate Bill 595. Hemophilia is a rare genetic disorder where the patient is missing a critical clotting protein. As a result, bleeding episodes can occur spontaneously in the brain, other organs, joints, and muscles, and are excruciatingly painful, can be life-threatening, and at the minimum, crippling and disabling. Clotting factor is extremely expensive, and no generic alternatives are available. After 29 years of hemophilia, I'm pretty savvy when it comes to health insurance. We're self-employed, and in November, I signed up at the Maryland Health Connection. We rely on copay assistance from the manufacturer to offset our out-of-pocket expenses. So I was quite shocked to learn the insurance carrier that I selected on the Maryland Exchange will soon be pocketing the $10,000 provided by the manufacturer for our benefit and will refuse to apply these funds to our deductibles and maximum out-of-pocket expenses. I read my 195-page policy, and nowhere is this information disclosed. By the time my son Jay was 18 years old, he had received more than 4,000 intravenous infusions in his veins and hands. His medication by the age of 18 was more than $16 million. Repeatedly sticking the same veins left track marks But I never really thought much of his track marks because they represented successful infusions of a life-saving medication to stop bleeding, to stop the bleeding episode. What I didn't consider was how a future employer might see those track marks. Jay had gone for an interview to be a lifeguard and so wore a lifeguard attire, including a short sleeve shirt. When Jay got home from the interview, I asked how it went. He said it was going great. The guy loved me, but then I put my hands on the table and I saw him look at my hands and arms, and the interview just ended. I think he thought I was a drug addict. Of all the challenges that my son have faced together in treating his bleeding episodes, that day broke my heart.
Melissa, can you wrap up, please?
I sure will. Hemophilia stole his innocence and childhood, and now insurance companies are stealing money given for his life-saving medication. Third-party copay assistance was meant for my son's care and not intended for the profits of insurance companies. Today, I'm asking you to vote yes on this policy for 3 reasons. 1, this is a consumer protection bill. Number 2, 19 other states plus DC and Puerto Rico have passed it. I
Okay,
will also
thank you.
share. We will be ahead of California if you vote yes. Thank you for your time.
I need you all to respect the 2-minute timer. We have a lot of people to testify, and if everybody starts going over, it's unfair. So I really need, everyone else is coming up to testify. Please respect the 2-minute timer. Senator Reedy.
Thank you, Madam Chair. I had a question. I was looking at the amendments, some of the amendments in some of the testimony. I've asked Matt a question about Care First has some amendments they've suggested, and I'm looking at them, and some of it seem, so there's an HSA one that seems like probably a good idea, or seems reasonable. There's some other issues. One of them is about limiting the accumulator ban to about covered drugs with no low cost. Can you just talk about what, like, I'm thinking maybe that you won't like that amendment. Can you talk about how that impacts consumers? Because it sounds good, but I'm trying to understand how it all works with the bill.
Sure. I'll kind of hit on that in 2 ways. One, I would just challenge the pretext of such an amendment because I think it makes this assumption that somehow patients or doctors are choosing high cost drugs for a patient. That is not the case. They are working through all levels of health plan design, prior authorization, step therapy to get to the point to access the medication that works best for that patient. So the idea that it should be limited or that there are other alternatives, I think is missing the point. And second, I would just touch on, as the data that we provided for the vast majority, 97% of the time that copay assistance is used, it's for drugs that do not have a generic alternative. And so I would challenge if it really would even have an impact on this legislation. So
you're saying that most of the time, if there's a cheaper drug and it does the same thing, generally physicians do they look at that? My experience is mine does. I don't know if
absolutely.
they all
Yeah,
do.
absolutely. Doctors would look at that. I can tell you from the patient perspective, we love generics, we love biosimilars and the idea of accessing cheaper drugs. It's just not always the case.
Okay. Thank you, Madam Chair.
Thank you. Senator Liam.
Thank you. I wanted to follow up on what Senator Reedy was also asking about, because I'm looking at some of these amendments and, I'm not, a big fan of this HSA exemption because I think it's really just shifting the costs in a different way back to consumers, but which is what I figured the payers would probably try to promote. When it comes to this accumulator ban on covered drugs that have no lower cost alternative, it's in a way really trying to steer providers and physicians towards other drugs that may not be helpful for patients, right? Some of these drugs are really unique and there may be no alternative. There may be drugs that are biologics that are really tailored towards the patient's needs. And even with some drugs, the equivalents may not have the same equivalent kind of impact on that patient that, one might think is equivalent otherwise. And so, I guess, is this just another way to steer them towards lower cost drugs and circumventing what the provider might otherwise prefer?
I would agree with that, Senator Lamb. Yes. I mean, I think it does 2 things. I think it tries to muddy what copay assistance is used for. It's not to target specific high cost drugs, just to use the assistance. And as you suggested, it really does interfere with the care relationship between patients and providers.
Right. So even this amendment that's being offered by Care First is just a way to kind of circumvent and insert themselves into the patient provider kind of relationship.
I agree with that, yes.
Okay, thank you.
Thank you, Senator. Any other questions? Thank you to this panel.
Thank you.
Next, we have four more favorable testimonies: Lance Kilpatrick, Kelly Schultz, Dana Kaufman, and Jenna Sublett. Madam Secretary, you must really like being down here.
I love it, Madam Chair. I get to go home earlier than you do, though, so thank you.
I think so. Lance, can we start with you?
Yes, Madam Chair. For the record, Lance Kilpatrick, Maryland Government Relations Director for the American Cancer Society Cancer Action Network. I will try to give the committee back a little time here. The cost of buying cancer-fighting medications can be very expensive, as we all know, often running in the thousands of dollars. For those with high deductible health insurance policies, the out-of-pocket costs for these medications can be incredibly burdensome and prohibitive. In our 2022 ACS CAN Survivor Views survey, over 70% of respondents were worried about affording care. Half of cancer patients and survivors reported incurring cancer-related medical debt. Women and African Americans in particular were most likely to experience cancer-related medical debt. So, in summary, insurers and PBMs shouldn't be able to get paid twice for the same medications, leaving patients holding an empty wallet. Please report this bill favorably. We thank you for your time and consideration.
Hey, Lance. Who's next?
I can go next.
Okay.
Good afternoon, Chair Beidel, Vice Chair Klossmeyer, and members of the Finance Committee. My name is Jenna Sublett. I work with Cornerstone Government Affairs, and today I'm here on behalf of our client, ALS Association, in support of Senate Bill 595. For those who are unfamiliar with the disease ALS, it's commonly known as Lou Gehrig's disease, and it's a fatal progressive neurodegenerative disease that slowly takes a person's ability to walk, talk, eat, and eventually breathe. The cost of care for someone living with ALS has out-of-pocket expenses reaching upwards of $250,000 per year. Those with ALS take various drugs to maintain their health, and the copays associated with those drugs add to the financial burden on patients and their families. One way that patients can afford their care is through copay assistance programs. However, insurers and pharmacy benefit managers increasingly use copay accumulator adjustment programs to prevent that assistance from counting towards patient cost sharing. These copay accumulator adjustment programs don't just financially harm patients, but they also undermine their access to life-saving prescription drugs. Those suffering with ALS or other complex medical conditions certainly don't need one more complications in their lives. All patients should be able to afford necessary treatments by ensuring all payments are counted towards a patient's deductible and out-of-pocket maximums. Thank you for your time. We request your support for Senate Bill 595.
Thank you. Secretary.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. And I am back here again for a good reason, I believe. I'm Kelly Schultz, and I am the CEO of the Maryland Tech Council. And you have heard the issue. I have been in here frequently talking about issues that relate to the economic well-being and the growth of the ecosystem within Maryland for life sciences, research and development, innovation. But I also have the very good fortune of sitting, I guess it's the very good fortune of sitting on the Prescription Drug Affordability Board stakeholder group. And because I was here opposing a bill that was to expand the PDAB, in expanding it beyond what its current breadth is in statute, I think it's important to come and talk about a different alternative. And I think Senator Hershey in this bill, Senate Bill 595, does talk about something with prescription drug costs, and it provides an alternative to what we have been routinely talking about, which is upper price limits. And I think this is a great way to look at the cost to the consumer, to the patients and their families in a way that will help to alleviate a lot of that financial pain and burden, and actually do what we're intending to do when looking at prescription drug costs, which is looking at some of the root causes of that. So with that, Madam Chair, I will just say me too on the rest of the topic. Thank you.
Thank you very much. And Dana?
Chair Bidle, Vice Chair Klossmeyer, members of the committee. My name is Dana Kaufman. I'm here today on behalf of MedChi and the Maryland DC Society of Clinical Oncologists. You have my written testimony, so I'll be brief. MedChi and Medesco support this bill really for the main reason that it has been shown in other states to lower healthcare costs for patients and also assist patients in adhering to their medication regimen. We've heard that there's some amendments. We'll be reviewing those amendments and we request a favorable vote. Thank you very much.
Do I have any questions for this panel? Thank you all for your testimony. Next, I have two people favorable with amendment, Matt Celentano and Tricia Swanson.
Madam Chair, Ms. Robinson, I think signed up opposed, but it meant to sign up FWA.
Ms. Robinson, anywhere on the list? Let me check. Go ahead and start, Matt.
Okay. Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP, favorable with amendments on Senate Bill 595. As introduced, the carriers have lots of issues with this bill. Senate Bill 595 endorses practices drug manufacturers employ that are explicitly forbidden in federal health programs like Medicare and Medicaid because they have been deemed as illegal kickbacks. By even introducing the bill, the manufacturers acknowledge their drugs are unaffordable to patients. But rather than simply lowering the price, they offer copay coupons, vouchers, discounts, or payments to offset cost-sharing expenses to hide their exorbitant prices. Drug manufacturers strategically offer these promotions to a narrow set of patients for a narrow selection of drugs and often only for a very limited time. Basically, the most expensive drugs. They want you on those, not the cheaper alternatives, and just as effective. Offering a kickback coupon ensures you stay on those expensive drugs. There is a ton of academic research, Harvard, Northwestern, UCLA, the list goes on, that clearly shows that these schemes are just an opaque way of passing along more costs to plans that are masked as consumer protections. That being said, we are forward with the amendment because there is a way to fix this bill to make it actually consumer friendly and lasting. Our amendments would make that possible by extending the coupon to a full plan year, no coupon if there's a generic alternative, and the IRS language, which is there because we can't preempt federal law. So we respectfully ask the committee for a favorable report on the consumer protection amendments. Thank you.
You actually submitted your amendments to us.
I believe that Mr. Swanson did for the carriers.
Thank you.
Yeah, Madam Chair, Madam Vice Chair, members of the committee, Tricia Swanson on behalf of Care First. I'll be very brief since some of the amendments were discussed already. The only thing I'll add is that Care First also serves has members in DC, and the proponent panel referenced that this bill had passed in DC, and that's accurate. We actually worked on it in DC, and they have the generic amendment language for the DC bill. So I'll just add that and would request favorable report with the 3 amendments in my testimony.
Thank you, Ms. Swanson. I do see those here. Thank you. Ms. Robinson, we don't have you anywhere. You're not on the list at all. Thank you. Any questions for this panel? Senator Lamb.
So to, I guess, follow up on my earlier question, there seems to be an implication that doctors would steer patients toward more expensive drugs intentionally based on some of these incentives, which I think is probably inaccurate, but that seems to be the implication that, we seem to be getting from some of the testimony that's been put forward and also some of the opposition's, contentions as well. I don't think that doctors are making decisions based on, the incentives that are being provided and intentionally selecting higher cost drugs. But they're making the best decisions on what's tailored to that clinical considerations for that patient.
Sure. Nobody disagrees with you, Senator Lamb, but this bill isn't about steering patients to drugs. It's about the coupons that are offered by the manufacturers to incentivize you to be on the higher price drugs.
But I think the clinicians are picking the best drug for the patient that works the best for their clinical condition.
That's fine. Then we should extend the coupon for the year to make it even more consumer protection built into this bill. If the doctor wants to go to the higher price bill or the higher price drug and pharma's going to offer a coupon, they should extend it for the entire plan year. Why not? Otherwise, it would just be sort of a wolf in sheep's clothing. What are we doing with the coupons in the first place then?
Okay.
Senator Hershey?
Thank you, Madam Chair. Matt, are you saying that the doctor is more concerned with what's higher cost than it is to take
Not
care
at
of the
all.
parent? It sounds like that's what you said. You
Not
said
at all.
Almost like there's an incentive for the doctors to do that.
No, there's an incentive to use the coupon to use for the higher price drug. And then after 3 months, when the coupon expires, the consumer is still sort of made whole, but then it jacks up the price to the insurance plan, which in turn ends up raising the premium for everybody.
And if I can answer just on behalf of Care First, I'm in no way implying anything that's been said here. I think we're conflating two different issues, but I don't want it to be summarized or stated on the record in any capacity that Care First is saying that doctors get a kickback for prescribing a higher. That's not what I'm saying in the slightest.
Well, I appreciate that because that's certainly what it sounded like.
Well, and
That's
I-
not what we're trying to
I
apply.
want
think
to make
a
it
lot
very
of us-
clear that that's not Care First perspective on this at all.
Okay, well, I can appreciate that. Matt, I do want to also say that these, the copay assistance is not just offered by the manufacturers, correct? It's offered by.
For the coupons, they coming directly from the manufacturers.
There's also assistance that comes from nonprofits and charities as well too, right?
That's not what this bill is about. This bill is about the coupon that comes from the manufacturer.
It can come from multiple third parties.
And that's not my understanding on this bill.
Well, I think what you're saying is it just had to, that it's just something that seems to be done by the manufacturers. But as I understand that there are multiple entities that can provide these types of discount coupons and cost
Discount
shares.
coupons and patient assistance programs are two completely different things.
Explain.
Well, a coupon comes from the manufacturer for the drug that they are trying to have you take. The patient assistance is totally different and goes to assisting the patient to buy the drugs. It's not built into the drug price chain.
No, I don't think that's accurate either. I think what we have been talking about is the third-party assistance that could come from multiple sources to drive down the initial cost at the time when, especially like right now, when patients are having to pay deductibles, pay off their deductibles before that's relieved. And that's what these coupons have been able to do.
Sure. Well, if that's the case and you want to relieve the out-of-pocket costs, then let's make the coupons last for the entire year of the plan year to coincide with the way you purchase your
Right.
plan.
So you put that amendment in and that essentially guts the bill.
Why does it gut the bill? It helps the consumer.
I guess, Matt, we could say the same thing. Why couldn't insurance carriers just decide that they're not going to charge patients for certain drugs?
Well, we don't have that option, sir.
You don't?
No, because every year that when we file our rates, it goes to actually justified to the MIA, and there's an MLR structure. It's highly regulated to get your premium out to the public. Not the same way for the manufacturers.
When you determine your formularies for what prescription drugs are included, you decide what the costs are for that, right?
No.
You work with the manufacturer.
It all goes back to the list price, and the carrier has absolutely no choice on what the list price is. It has no sort of input into what the list price is.
And so you're saying you're just passing along the list price?
No, I'm not saying we're passing along
Right,
the
then
list
what are you doing
price.
with it then?
Well, we have to build the formulary and the plan around what the
That's what I
list
just
prices
said,
are,
right.
because we have no control over that, and they're artificially inflated to try to take a bigger cut from the insurer.
Okay, so Matt, what you and I just said, the same thing, different ways. We talked about, you guys are responsible for putting the formularies together.
Correct, but the
based on
difference
list
is that
prices.
the insurer is actuarially justified in the way the rate goes out to the public. The manufacturers have no regulatory structure to try to justify their list prices that have been going up thousands and thousands of percent over the last decade or so, and there's no justification for it.
Okay, well, insurance premiums have gone up as well too, and of course, any opportunity. that
Have
the
they gone
carriers-
up in the fashion that the prescription drug costs have?
Any
I would beg to
opportunities
differ.
that the carriers can blame it on the manufacturers, you've done a great job of
Well,
doing
Senator
that.
Hershey, I'll say that like 10, 15 years ago, the percentage of your premium that went to drug costs was between the 5 to 7%. It's now 35%. There is incredible inflation going on in the prescription drug space that is not due to straight inflation. It's because they can get away with it.
It also might be to the fact that there are drugs out there that are doing more work, that are helping patients better, that have taken a long time to get to where they can be delivered. There's all kinds of things that are going up.
Well, if that's the
healthcare
case,
has
then
gone
why
up
isn't
all-
pharma at the table? They're not here at the table. They
This
never
isn't just-
justify it,
Because this isn't just about pharma.
but it's a pharma bill.
It's not a pharma bill.
They actually, in the prescription drug affordability hearing, they actually suggested that it was their bill.
Okay, so if it is a pharma bill, then it must be that the insurers and the PBMs have to be against it because the three.
I
of you
didn't
guys
say we
could
were
not
against
get
it. We're
along.
here favorable with amendment. And if with the three, I think consumer-friendly amendments, we're in favor of this bill.
Madam Chair, I appreciate that. And Matt, you know that amendment guts the bill, but
Senator, you always see my evil eye. I don't know.
I can feel it, Madam Chair. Thank you very much.
Thank you. Do I see any other questions for this panel? Thank you very much. I think that's an interesting discussion maybe to take offline. All right. Thank you very much. Next, we have unfavorable Heather Cascone, Michael Johansson, and Camille Fesh.
Senators, thank you so much. Hello, Heather Cascone again for PBMs. We are opposed to the bill. I want to say at the outset that PBMs do not oppose means-tested patient assistance programs that help individuals afford their prescription drugs. There is, however, a difference between means-tested assistance programs and co-pay coupons, which we are talking about, that are targeted to insured individuals. Drug coupons encourage patients to subvert the health plan that benefits them financially. Coupons are marketed as short-term relief for copay assistance, but they encourage patients to disregard formularies, disregard lower-cost option drugs in favor of specific drug companies' more expensive drugs. This coupon system undermines the concept of formularies and has the reverse effect of lowering healthcare costs, and instead steers patients to higher costs. A report from the National Bureau of Economic Research in my written testimony found that prices for drugs with coupons increased 12 to 13% faster than comparable drugs with no coupons. Coupons are a sneaky bait and switch because patients likely pay more when the coupon goes away and will see higher premium costs in the long run by forcing the plan to pay for the more expensive drugs. Thank you. I'm happy to take any questions from the committee.
Hi, Camille Fesh, here along with Heather Cascone for the record. Hello, Madam Chair, Madam Vice Chair, members of the committee. Echoing everything that as Heather had said before, we have not yet seen the amendments, but we are reviewing them. They do seem like something that we'd be potentially in favor of, but again, must review before we could switch to favorable with amendments. And just a couple of small points. The formulary is a very important mechanism that PBMs use to balance the cost of prescription drugs. Also, the number and the amount and the cost of prescription drugs, they become more sophisticated over the years. They become much more expensive. It was mentioned earlier, the percentage of your insurance premium that goes towards prescription medication has increased significantly. And these things all have to be taken into account. And when entities come in from outside of the system, and they have coupons that do affect how the patients use the system, what they pay towards the system. It ends up affecting all of the patients that are in a healthcare plan. And Heather has gone over some of this, but we expect that there will be that coupons are responsible for a $32 billion increase in spending on prescription drug and commercial plans. And if Medicare's ban on coupons are not enforced, costs of the programs would increase $48 billion over the next 10 years. So we encourage you to think very carefully about this issue and very carefully about any amendments. Thank you very much, and we're here for questions.
Thank you, Madam Chair. Camille, just to make sure I understand your last part about Medicare's ban. Medicare doesn't allow copay assistance, correct?
That is correct.
That's right already. And then Heather, you referenced coupons are responsible for a $32 billion increase. That was from a report that was 12 years old. Is that right?
That's from. Yes, that's from a report that's from 2011, but the facts stand.
The name of that report was How Copay Coupons Could Raise Prescription Drug Price by 32 billion over the next decade. Have they not updated their report in 12 years?
I can't speak for the researcher, sir.
Okay, so that's you're essentially stating
there's certainly
I just want to make sure because you said that the coupons were responsible for a $32 billion increase. The report said that it could. The report's 12 years old. One other question. If a patient uses copay assistance, the PBM gets paid, correct?
Are we talking about a coupon or patient assistance, charitable assistance?
I'm talking about copay assistance.
Coupons is what we're talking about. Okay.
You get paid. The PBMs get paid.
No, sir.
Does the PBM get paid on copay assistance?
No, sir.
You don't get paid at all.
No, sir.
So tell us what happens when a patient uses copay assistance.
When a patient uses copay assistance, they do not have to pay any copay at the point of sale of the pharmacy counter. Instead, the health plan bears the remainder of the cost of the price of the drug.
You're saying
Oftentimes, that drug is a more expensive drug than other alternatives in the class, which is why we have formulary designed to encourage patients, when there are alternatives available, to choose the lesser expensive, higher, in many instances, lower tiered formulary drug, because it's more advantageous for both the patient, the plan sponsor, and all of their interests are aligned.
Okay, I think we keep going back to the patient choosing the medication is what
No,
you're saying.
that's not what I said.
What did you just say that? Please?
When a prescriber writes a prescription for a prescription drug, if there are other alternatives in the class that are less expensive, that information is communicated to the prescriber, and the patient has the opportunity to take advantage of another therapy that could be less expensive for them. Unfortunately,
Okay, I thought that's what you said. Okay, so
unfortunately, though, when a patient is offered a copay coupon, their incentive is to choose the higher priced drug.
And is there a 12-year-old report that says that as well too? I mean,
There is, however, a report that says that drugs with coupons increase to a rate 12 to 13% faster than non-coupon drugs.
Right.
So there's
okay.
clearly an increase here.
I think we're getting back to the same point. I think at the end of the day, and I'm sure my colleague might want to talk about this as well as a physician, that the physicians are prescribing the drugs that best benefit the patients. And I would be surprised that a lot of this conversation about coupons and copay assistance and what you're going to pay and what the deductibles are, they may occur, but I think at the end of the day, the patient wants, the prescriber and the physician wants to make sure that the patient gets the best prescription that's available to them.
Absolutely. And certainly drugs don't work in patients who can't afford to take them at all. And so it's in everyone's interest to be mindful of the cost of that treatment.
I appreciate that. And Madam Chair, that's why we have this bill in front of us. I appreciate it.
Thank you, Senator Hershey. Senator Lamb, you're next.
Yeah, I mean, even in that exchange there, it sounds like your contention is that the patient chooses the higher cost drug because of the coupon, but the patient doesn't choose the drug. The provider prescribes the best drug for the patient, right? And so I'm not sure I understand how the patient is choosing the higher cost drug.
At some point, when a lesser expensive alternative becomes available, that patient might be less likely to switch to the other alternative, less expensive drug because they are being incented to stay with the drug that is being couponed. As a result, they pay less. Their incentive is different. They're not aligned with their health plan sponsor. They don't have any skin in the game of the cost of this therapy for them because they are being couponed. They have a drug that's being couponed. They're not giving the chance to take a lesser expense medication.
But the patient doesn't make the switch. It's the provider that makes the switch.
But if there's a generic or a lower cost alternative that's available, they will never choose that choice if they're not being offered.
So you're
a
saying the
coupon.
patient should do their own clinical investigation to
coupons
figure
are
out
not
what
being-
lower
I mean,
costs.
The coupons are being offered at the pharmacy counter to the patient, right? So they're choosing to stay out that drug and accept the coupon or not. I've never heard of a patient not accepting the coupon and not stay. When they have no copay to pay, they're going to make that choice for the higher cost drug, but the higher cost is being borne by the plan.
Well, they're
not
making
by
a
the
choice to
patient.
stay with a drug that works.
Not necessarily.
And so they're supposed to play doctor and
No,
making the
they're-
decision of what,
As well,
look,
there
standing
are-
at the pharmacy counter, choosing this drug or that drug, the patient's supposed to make that decision?
Right, but as well, there are many therapeutic alternatives in a class, and oftentimes some
And
are
the patient's
far.
supposed to know that.
Well, the doctor should be, and I'm sure you do, have a conversation with your patient about what's covered and at what degree, and what their out-of-pocket expense would be, because certainly if it's an unattainable expense, then that's not a helpful therapy for them.
Okay, well, to me, it sounds like you're putting this decision, the clinical decision judgment back on the patient, which doesn't make a lot of sense. And I want to follow up on the earlier point too, that it was mentioned that this was a pharma bill. But isn't it true that almost all of the favorable testimony here are from patients and providers?
I didn't make that statement, but my understanding is that the amendments that have been offered in many places. They've been considered by a number of legislatures. I think it's worth noting that if the coupon is a meaningful way to lower drug costs for patients, then it should be offered and honored on an extensive basis, because otherwise all it does is seek to bait and switch that patient onto a more expensive drug that doesn't benefit them financially in the long run.
It seems like it's you all that are bait and switching the patient, but if your position is all about the patients, why are there no patients and providers on your side?
My position is that the interests should be aligned between plans and patients.
Okay, well, for the
And
record, there are
coupons subvert that.
there are no favorable testimony in support of your position from patients or providers.
Thank you, Senator. Are there any other questions for this panel? That ends the hearing on Senate Bill 595. Senator Gallion is here. We're going to do Senate Bill 778. And Senator Gallion, I think you have Matt Celentano as your panel member.
Yes.
Okay. Where's Matt? There he is.
I don't usually come up early. You can see it. Ready?
You're welcome to begin. You have all the time you need,
I won't need much.
and your panel member gets 2 minutes.
Okay. Good afternoon, Madam Chair, Madam Vice Chair, and Finance Committee members. For the record, Senator Jason Gallion here representing District 35, Harford and Cecil counties, to introduce Senate Bill 778, Health Insurance Hearing Aids for Adults Coverage. Currently, minors in the state of Maryland are eligible for a max benefit payable limit to $1,400 per hearing aid for each hearing impaired ear every 36 months. This legislation simply expands the limit for adults to be in line with the benefit limit provided to minors. Senate Bill 778 will help adults with hearing loss overcome the economic obstacles that often leave individuals untreated and without hearing aids. There is one amendment that through collaboration with the various health insurance groups that specifies coverage will be provided if the hearing aids are prescribed, fitted, and dispensed by a licensed audiologist. I respectfully ask the committee for a favorable report to assist our hearing impaired adults gain greater access to hearing aids.
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers. I wasn't accustomed to coming up at the first panel, so I wasn't prepared. But I will say I want to thank Senator Gallion and the MHCC for helping us understand exactly where this bill was and the cost impact, and we would urge a favorable report.
Thank you. That's the most positive testimony of the day. Do I have any questions for this panel? Thank you very much. That'll end the hearing.
Thank you.
That ends the hearing on Senate Bill 778. And next, I think Senator Augustine is here. Senator Augustine was to be bill number 3. He's now almost at the end. Senate Bill 684, Senator Augustine. You have a panel?
Yes. Thank you, Madam Chair. Apologize for missing my spot by a few minutes. I do apologize. I know that we do have our panel folks here who are going to come up. Thank you, Chair Bidle, Vice Chair Klausmeyer, members of the committee. Senator Malcolm Augustine here on behalf of that bill. On behalf of Senate Bill 684, Mental Health and Substance Use Disorder Benefits, Sunset Repeal, and Modification of Reporting Requirements. You all are keenly aware of the Parity Act and the fact that we have to treat a federal law says that we must treat somatic care the same way that we treat behavioral health services, mental health, mental illness, substance use, substance abuse by law. And the reason for that is because the carriers don't. And it's just the bottom line. And there are real gaps in making sure that we treat behavioral health the same way that we treat the physical health, that a person who presents with a broken arm is treated no differently than someone who presents with a form of mental illness as far as their treatment, with regard to insurance and insurance carriers. This committee, a few years ago, put in a framework to hold the carriers accountable for the Parity Act. And that framework of reporting requirements basically didn't work. And that's pretty much what the report that the Maryland Insurance Administration came back with. Has not been able to receive adequate information to ensure that there's compliance with the Parity Act. And they issued a report that said that they needed certain changes to the legislation that we passed that dealt with this Parity Act compliance in order to be able to more effectively make sure that this compliance was occurring. This bill, Senate Bill 684, in essence, takes the recommendations from the MIA and says, and puts them into a structure in order to make sure that we're getting what needs to be reported, making sure that they're able to hold the carriers liable for whether or not they for the reporting itself, and then also for the underlying treatment that they are or are not providing. This is responding to that from the MIA. Colleagues, I will share with you that we have been working with the MIA. We also have been working with some of the folks in the House who I've worked with, quite a bit on these types of matters in the past to try to come to a place that makes some sense, where we get to a place that makes sense. I still feel and believe that this piece of legislation that you have before you really does respond to it. And that's why we're here to present this. But do know that we are working together to try to come up with a solution that makes sense. And so at the end of the day, we want to make sure that we are making sure that these carriers are complying with the federal law, and that we strengthen the MIA to make sure that they're able to do that. And so I'm going to ask for a favorable report on Senate Bill 684. Thank you.
Thank you very much, Senator. Lori, would you like to go next?
This is
I'm sorry. Ellen.
Yep. Thank you, Madam Chair, Madam Vice Chair, members of the committee, and thanks, Senator Augustine, for being such a strong advocate on parity. We also want to thank the MIA for its illuminating report and for working so hard to enforce the Parity Act. Compliance reporting is so important because it really is the only way that consumers know whether they are buying fair coverage of mental health and substance use disorder benefits. And the most important step that this committee can take to enforce all of our rights to fair coverage of mental health and substance use disorder services is to explicitly place the burden of persuasion on carriers to demonstrate that their plans comply with the parity standards. Now, this is important for three reasons. First, the MIA proposed this very standard in 2020. The carriers opposed, and as a result, the MIA has not been able to make a substantive determination of compliance for any carrier. This will actually reduce the MIA's administrative effort. It's a waste of time and money to require the MIA to review carriers' reports without this standard. Secondly, federal law puts the burden of persuasion on the carriers for compliance reporting. And third, carriers possess all of the information that's needed to demonstrate compliance. So carriers have the burden of persuasion in consumer grievances and appeals because they have all of the information that's necessary on that challenge denial. And the same must apply here on the Parity Act. Now, the remedies that flow from this persuasion standard will actually break the logjam that the carriers have created through their playbook. They don't submit complete analyses. They don't give the MIA the information it asks for, and then they appeal any penalty that's been imposed. And so Marylanders are the ones who lose as a result. And unfortunately, as Senator Augustine has mentioned, after all of your work and all of the work of the MIA, we really are no closer to ensuring that there is equitable coverage of mental health and substance use disorder services nearly 4 years after you passed the original legislation. So we thank you for your consideration, and we also request that you issue a favorable report.
Thank you, Ellen. And Ann.
Good afternoon, Madam Chair, members of the committee. I'm Ann Seacott, testifying on behalf of several clients who have testimony from the National Council on Alcoholism and Drug Dependence, the Maryland Addiction Directors Council, and Inseparable. And we are testifying in strong support of Senate Bill 684. If you haven't read the MIA's report that was issued based on the legislation you passed 4 years ago, it's worth a read. And what they do is make very strong recommendations about the things that need to be in place in order for them to be able to do their job. And we think that this bill absolutely reflects those recommendations that they made. I just want to spend one moment talking about non-quantitative treatment limitations, NQLTs. TLs. See, I can't even get it right. I do that all the time. Treatment limitations, that's one of the issues that's in the bill, that was in the recommendations around. We just want to say that while the MIA and some of the discussions happening across the street are about, trying to just limit the number of treatment limitations that are collected and analyzed, just want to make sure everybody understands. Insurance carriers are responsible for compliance and for doing the analysis that they are compliant on every single treatment limitation. And so to have a few reported, we think is reasonable. But we also want to make sure that we're not telling the carriers, oh, it's going to be these 4 or 5. Because we might just be ending up sort of teaching to the test kind of thing. So just wanted to say that, and then put a plug in for this burden of persuasion that we think is really important. Thank you.
And Lori.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland in support of this bill. It has been over 15 years since the Federal Parity Act passed, yet here we are today trying to find out how to ensure that carriers are complying with the law. And this is really important, as Ms. Weber said, because the MIA cannot make determinations about federal parity complaints brought to them if they do not have adequate information. In other words, a carrier can dodge a parity violation by simply failing to provide adequate information on their compliance reports. So they may be subject to a fine for doing that, but it's not a very big one, and it can be seen basically as the cost of doing business. So this whole provision of the burden of persuasion is important. We have had providers go to the MIA with parity complaints only to be told that the MIA cannot make a determination. We don't want to reward carriers for failing to submit adequate parity compliance reports. It's a get out of jail free card, basically. And I wonder, Madam Chair, after these 15 years and over these 15 years, how many people with mental health and substance use disorders have suffered because they don't have access to care? We've waited for a long time for this bill to be seen and complied with. So we believe that adequate reporting and sufficient penalties for failing to do so are necessary. We urge a favorable report. Thank you.
Thank you. I think that ends this. You have a question? Senator Klausmeyer has a question.
Yeah. How is this burden of persuasion done currently? Is just through the insurance companies, or when do the carriers fill out these compliance reports and send them? What would make it easier?
So thank you for that question, Senator Klausmeyer. Right now, we think the federal law actually does require the burden of persuasion to be on the carriers. They're required to demonstrate compliance, and Maryland law also requires that as well. We think that perhaps the MIA is not exercising some of the authority that it really does have, and that's why we need this explicit standard in place. They are supposed to demonstrate through an analysis and a presentation of information that they aren't discriminating. But that is not what they are doing right now. They are not supplying sufficient information to show that they do not discriminate. And therein lies the problem. Under federal law, if they can't show that they're not discriminating, then they should not be allowed to offer that plan. The federal law bars carriers from offering any plan that doesn't comply with these standards. If they don't show it, they should not be allowed to offer the plan.
Well, I'm just a little, I guess I'm confused. So, but we don't know that they're doing that. How do you make sure the carriers are doing it? I guess is what I'm saying.
How do we make sure that they're doing it? By virtue of the fact that says if you don't submit a completed report, And if after the MIA has asked for more information, the carriers still fail to demonstrate there's compliance, that's when they should be, been found in violation of the law.
Okay, so it's up to the insurance administration to say, hey, I didn't get the right amount of information, get back here.
That's
And-
right. And that's what they've been trying to do. But every time they have tried to do that, as the report demonstrates, the carriers still fail to provide the information that shows that they comply with the law and that their plans are non-discriminatory.
So this bill will make the insurance administration go after them, give them more teeth, right?
You're right.
Okay.
They are going after them. They just need more teeth to say, you haven't demonstrated it because you haven't submitted the information. That means you're in violation. You cannot sell this plan, or you have to correct this, or there are other remedial steps that we will take to ensure that it is fair.
Okay, thank you.
Thank you.
Any more questions for this panel? Thank you very much. We have two more favorables, Dan Martin and Courtney Bergen.
All right, Madam Chair, members of the committee, Dan Martin here in support of Senate Bill 684. Like the prior panel said, it's been 15 years since Congress passed the National Mental Health Substance Use Parity Law, but it's actually been 30 years since Maryland in 1993 passed the first statewide mental health parity law in the nation. And regardless of these legislative steps, the discriminatory practices and failure amongst payers to comply with the statutory requirements continue unabated, while the unmet demand for mental health and substance use care continues to grow. And an interesting bit of history, the Maryland Behavioral Health Coalition, which my coalition chairs, and which my organization chairs, now upwards of 100 organizations from around the state. Many of you are familiar and have spoken at our rallies, and thank you very much. That organization, that coalition actually got its start in 1993, advocating for that statewide parity law. It was just 4 organizations advocating for that parity law. And still, 30 years later, we're struggling to make sure that it's enforced appropriately. But now, thanks to the legislation that this committee helped to spearhead back in 2020, and thanks to the stellar work of Insurance Commissioner Brain and the Maryland Insurance Administration in implementing that law, we have this eye-opening report that the last panel mentioned that was released in December with recommendations for new reporting requirements and regulatory enforcement authority that will give us the best chance that we've had in a generation to ensure that these critical anti-discrimination laws are appropriately implemented and vigorously enforced. And like the sponsor said, there's a lot of work going on. No, there's a lot of work going on over in the House with the Maryland Insurance Administration and with the House sponsors of different bills. And so, you know, I am confident that whatever comes out of that process is going to give us the best chance that we have to really, again, make sure this law is appropriately enforced. And so urge you to support this bill and whatever comes out of that process. Thank you.
Good afternoon. My name is Courtney Bergen. I'm an attorney and Equal Justice Works Fellow at Disability Rights Maryland. And importantly, in the context of this bill, I'm also a Baltimore City resident with a significant mental illness. And Disability Rights Maryland supports this bill, SB 684, because Maryland's lack of parity compliance and enforcement is impeding our clients' access to the care they need to thrive. This is a disability rights issue and a health equity issue. Strong parity compliance is essential to ensure access to mental health services, which I can speak to from both my personal and professional experience. When I moved here in 2019, I had been recently discharged after spending almost a year in a psychiatric hospital. With the help of a case manager, I contacted more than 50 in-network providers on my state-regulated insurance plan, and I couldn't find anyone due to inadequate provider networks. So I requested a single case agreement. Took months. It wasn't until I testified before this committee that I got that care. Now I just had to go through the same process 5 years later, and it was only worse than it was in 2019. It took me over 5 months to get the single case agreement with the same providers executed. Last time that kind of delay happened, I ended up in Shepherd Pratt for 5 months. The same thing is also happening to my clients on a regular basis. It means that many of them are ending up unnecessarily hospitalized and not being able to live the life that is most meaningful for them. If we can have a strong parity compliance and enforcement mechanisms in Maryland, Marylanders can have a much better chance to participate in their communities, to thrive, to be someone, I got the exception to the rule in many ways and ultimately being successful, but other people deserve that same opportunity that I got so that people can have the opportunity to live the life they deserve. And so DRM asks for your support on this bill.
Thank you. Do I have any questions for this panel? Thank you both for your testimony. Next, we have favorable with amendments, Matt Celentano and Allison Taylor.
Madam Chair, members of the Senate Finance Committee, once again, still Matt Celentano, still here on behalf of the League of Life and Health Insurers of Maryland. We are favorable with amendment on Senate Bill 684. First and foremost, we are absolutely willing to continue to engage in the discussions on this bill and other efforts introduced, and we'll be at the table to work on it this session. We appreciate the sponsor's recognition that the reports have proved challenging. We absolutely agree. Accordingly, we appreciate that Senate Bill 684 includes a number of provisions to focus on the reports and the review of the non-quantitative treatment limits identified by the commissioner as having the greatest impact on patient access to care. League members are very much aware and understand that the access to mental health and substance use disorder treatment remains a critical issue. Rather than creating burdensome regulations and data polls that don't solve the issue, we want to get the right information to make the right decisions. As Ms. Seacott referred to, and the amount of NQTLs and how we talk about that is important. And we're going to be at the table with the MIA, the proponents and other advocates, as well as the House folks to make sure that we get a product that you can be proud of by the end of this session. So thank you very much.
Thank you, Matt, for your work. Do I have any questions for Mr. Celentano? Thank you very much. I have two people from the MIA for information, David Cooney and Mary Kwai.
Thank you, Madam Chair, members of the committee. For the record, I am David Cooney, Associate Commissioner for Life and Health at the MIA, and I appreciate the opportunity to provide information on Senate Bill 684. As you've heard other panelists testify, the original NQTL bills that were passed by this body in 2020 specifically directed the MIA to report back to the General Assembly with recommendations for improving the reporting process. We issued that report in December, describing in detail the significant challenges with the existing process, and we are extremely pleased and grateful that the General Assembly has introduced 3 bills this session, including Senate Bill 684, that seek to implement the MIA's recommendations from the report and help ensure that the MIA has the tools needed to improve consumer access to behavioral health care. We do, however, have some concerns with the bill as introduced that it may not accomplish the desired goals because some of the MIA's recommendations were not fully implemented. We are currently working with the sponsor to attempt to address the technical and substantive issues we have identified with the bill. To briefly touch on one of the most important issues, Senate Bill 684 already includes a provision placing the burden of persuasion on the carrier and any determination related to parity, and this is a critical amendment to the existing law. However, based on our experience reviewing these reports thus far, it will be essential for the MIA to have the ability to take additional actions other than just imposing fines or simply requiring the carriers to eliminate an NQTL entirely. Fines are not effective in every situation, and for certain NQTLs, such as requirements related to medical necessity and provider credentialing, ordering the carrier to completely cease the practice would be extremely disruptive to the market as a whole, and it would have adverse consequences on many consumers. For this reason, the MIA is seeking the authority to order carriers to modify, rather than just cease the disputed practice, to submit additional periodic data to evaluate an NQTL in operation, to pass the cost of the review onto the carrier in certain situations, and when appropriate, to direct carriers to establish objective quantitative thresholds for determining whether or not they should apply an NQTL. These additional enforcement tools are needed by the MIA to effectively implement the Parity Act.
Thank you, Commissioner. Mary, did you want to also testify?
Yes, thank you, Madam Chair. And thank you for the opportunity to provide information regarding Senate Bill 684. My name is Mary Quay. I'm the Associate Commissioner for Market Regulation and Professional Licensing at the MIA. The MIA has monitored the actions of other states and federal regulators on parity. Some states require filing of all NQTLs, but tend to perform only a cursory review with limited follow-up action. Other states and the Federal Department of Labor limit the number of NQTLs they review and dive deeply into the carriers' reports to ensure that carriers are performing strong analyses and not just going through the motions. And then they seek a consent order for compliance oversight going forward. The goal is to ensure parity and to promote consumer access to care. We believe we can best achieve these goals by focusing on meaningful compliance with fewer carefully selected NQTLs. More robust data to support analyses would be available at the product rather than the plan level. For example, an HMO that requires referrals and does not have out-of-network benefits is a product. The plan would be that product at each separate deductible level that the carrier sells. And that would have a much smaller enrollment. If we ask for data on prior authorization requests at the product level, we will receive a larger data set than if we ask for compliance at the plan level. And the NQTLs are applied at the product level. Biannual filings rather than annual would allow carriers time to make changes based on the prior year's reviews and to see if the changes make a difference in operation based on the data outcomes.
Thank you. Do I have any questions for David or Mary? Thank you very much. We have one final witness virtually, Laura Willing. Thank you.
Hello, thank you. Madam Chair, Vice Chair, and members of the committee, thank you for the opportunity to provide testimony in favor of Senate Bill 684. My name is Dr. Laura Willing. I live in Silver Spring, and I am a child and adolescent psychiatrist at Children's National Hospital. Nearly 60% of our patients are residents of Maryland, and we provide a comprehensive range of behavioral health services for Maryland children and youth. We know that many youth with health insurance have difficulty accessing quality mental health care in a timely manner. We have heard from providers and families that there are many barriers to care, including prior authorization, step therapy, limited networks, and long wait times for services. We believe that achieving true mental health parity is necessary to improve the current state of youth mental health. The comparative analyses required in this bill will help Maryland enforce state and federal parity laws. We suggest that these analyses are also made available to the public so that consumers can purchase plans that are in compliance with the law. We support this bill as is and have some suggestions for its implementation. We suggest that a stakeholder advisory group may be beneficial when implementing this in Maryland. The entire continuum of care should be covered within network. Further, if Maryland residents are frequently needing to find care outside of their carrier's network, that likely is not an adequate network. We also suggest gathering data on payment rates when comparing medical surgical care to mental health care. The Milliman report shows higher out-of-network utilization for mental health care as compared to medical surgical care. And it also shows frequently lower reimbursement rates for mental health care as compared to medical surgical care. I applaud Senator Augustine for introducing this important legislation, which will help more Maryland residents use their health insurance to access mental health care in a timely manner, and request a favorable report on Senate Bill 684. Thank you.
Thank you, Laura. Do I have any questions for this witness? I see no questions. Thank you for your testimony. And that ends the hearing on Senate Bill 684. Next, we'll have Senate Bill 626. Senator Reedy.
Thank you, Madam Chair. If I could bring up a panel.
Yes. Okay.
Okay, that's all right. We'll get that.
It's my first time.
Jim, you look them up. I think we have one other person. I think Kaylee Locklear was going to be here, but she may be across the street. So
Busy day.
we'll proceed. If she arrives, maybe she can join. Okay.
Do you have Heather Forsyth? Forsyth?
I'm also testifying in support. That's not part of this panel.
You can come on the next panel.
Okay,
So-
okay, let's just go.
Okay, all
Okay,
right.
Senator Reedy.
Thank you, Madam Vice Chair, members of the Senate Finance Committee, Senator Justin Reedy here. Excited to present Senate Bill 626, which deals with the definition of purchaser and alteration of application of law as it relates to pharmacy benefit managers. The House version of this bill passed the House last year. It did not have time to make it through the Senate. And what this bill does, Senate Bill 626, extends regulations that the Maryland General Assembly has placed on pharmacy benefit managers to protect patients and providers under state regulated plans to apply to patients under all ERISA plans. In keeping with recent Supreme Court ruling that gave states the authority to regulate PBMs, even those PBMs that are acting for a self-funded or ERISA regulated plan. In recent years, we've made the policy decision as a General Assembly to impose certain regulations on PBMs operating in Maryland, and none of those bills were passed lightly or flippantly. A tremendous amount of work was put into each of those pieces of legislation and to this entire issue. And ultimately, the legislatures determined that the policy and protections that were included in those prior bills were in the best interest of all Maryland patients. Senate Bill 626 simply extends those protections to all Marylanders, regardless of where they get their health insurance. These protections, and they're actually outlined well in the fiscal note, if you'd like to see it on page 2, but they include allowing pharmacists to freely and honestly share information with patients about the cost of their prescription drugs. It allows patients to choose where they go to get their medications. Fair and uniform reimbursement for drugs across pharmacies so that especially our smaller independent pharmacies are receiving parity, especially as they serve underrepresented and underserved populations. Requires certain rebates and savings to be passed on to patients, and requires a predictable and fair auditing process for pharmacies. These are all regulations that have applied to PBMs associated with state regulated plans for many years. Insurers continue to provide affordable and effective health care in our state. When this committee hears health insurance legislation, we often will hear about bills that we pass and policies that we enact that they only help a portion of Marylanders. And some of that, a lot of times that's okay, depending on how our system is structured for the different parts of the healthcare sectors. But this is our opportunity to really extend those protections to all patients. I fully support employers and their ability to provide affordable health benefits to their employees. Those decisions should be balanced with a patient's ability to access quality care and have transparency on how they access that care. Ultimately, the uniform application of pharmacy benefit manager regulations that we have passed previously across all Maryland residents results in more transparency and competition for how those patients access prescription drugs. This bill passed the House unanimously last year as a reminder. I'd urge us to do the same, and I would request the committee give us a favorable report on Senate Bill 626. And we're continue to be open for conversations with our friends who will come up in opposition. But it's really an opportunity now for us to move forward on this so that we have uniformity. And so with that, I'd ask for your support. Happy to take questions afterwards, but I'd like to turn it over to my panel, who definitely, I think, are folks that can really explain even more in detail why this is so important.
Do you want to be in any special order, or just Jerry, you want to go?
You go ahead. That's fine.
Thank you, Madam Vice Chairman and members of the committee. I'm Gerard Herpel. I own Deep Creek Pharmacy in Garrett County, and I'm here representing Epic Pharmacies and the Epic Pharmacy Network. We've been dealing with the repercussions of the federal ERISA laws in Maryland as they related to PBMs for many years. The state and this committee has always taken the PBM's assumption that their bait and switch business practices were protected by ERISA laws as a fact. Senate Bill 626 will clean up the Maryland statute and remove any mention or implication that ERISA preempts PBM legislation from Maryland's law and expand the regulations of PBMs to all plans and all sections of the law. These changes will have no financial impact on the insurance articles involved with ERISA. whether it be definitions, transparency, preventing the PBMs from self-dealing and restricting patients to use their pharmacy or their mail order pharmacy, which I see every day in Garrett County. This will not have a problem preventing PBMs from reimbursing other pharmacies less than it reimburses its own pharmacies that they own. Specialty and mail order drugs are excluded from this. A PBM can still run the bait and switch system on these claims since they own both sides of the equations in many occasions. Senate Bill 626 will allow the state to enforce all current PBM laws in a way that more uniformly regulates the industry and allows for a more level playing field. This ultimately benefits patients in Maryland. I would like to thank Senator Reedy for sponsoring this bill and the committee for all the work they have done working through PBM legislation in the past, and respectfully ask for your support of Senate Bill 626.
Thank you. I'm Jim Doyle. I'm here on behalf of the Independent Pharmacies of Maryland. Look, the independent pharmacies in this state have had a tough time for a number of years. And this is a bill that will eliminate some of the predatory practices that PBMs are now using against independent pharmacies. And so just very quickly, this bill will allow pharmacies to inform patients of other drugs that they may be able, or drugs that they may be able to obtain at a lower price. It will remove the gag clause. It will allow the choice of a consumer to pick the pharmacy that he wants to use. It will require that pharmacies reimburse for drugs, whether they own that whether PBMs own that pharmacy or affiliated with that pharmacy. They will reimburse at the same rate with other pharmacies. It will impose audit procedures that are fair to the pharmacy, and it will create appeal procedures for pharmacies to have the review and challenge of unpaid prescription bills. So it does a lot of things to eliminate these kinds of predatory practices that have been used. And it is consistent with the Rutledge decision from the Supreme Court that was passed a couple of years ago unanimously. And the Maryland Insurance Administration about 1 or 2 years ago did a study of these provisions and concluded that in fact these provisions did satisfy all the requirements with respect to ERISA preemption. Thank you.
Good afternoon, Madam Chair, members of the committee. Caitlin McDonough here on behalf of Epic Pharmacy Network in support of House Bill 626. I won't repeat what the previous panel has said about the legality of the bill, its relationship to the Rutledge decision or MIA's ability to enforce it. And just building a little bit on Senator Reedy's introduction, I mean, I think you can tell by the bills before you today, like nothing comes through this committee or the committee across the street or the General Assembly that would limit or regulate pharmacy benefit managers easily. I mean, these are things that are well vetted, and if they're in place, it means that this body's made a policy decision that it's in the best interest of patients and providers, and that's been balanced with the cost and impact on providing that health care. So those decisions have already been made for, a portion of Marylanders, and, based on the legal arguments laid out in Rutledge, this bill would just extend it to all Marylanders. And I think we are confident that the employers who sponsor these plans, the insurers who work through them would be able to continue to provide affordable and fair coverage, and also maintain these patient protections. So, with that, I'll give up. I just want to move for a favorable report on Senate Bill 626. What committee? What house am I in? Yeah. Senate Bill. So, I apologize. I was in the House 5 minutes ago. Yeah. I know.
Now, are there any questions from the committee? Okay, Senator Senator Hayes.
Senator Reedy, I think you're fighting for the top bill with the most opposition to it. I know you won't have an opportunity to respond to some of the opposition, but there's several pieces of testimony in the bill file that said that there's no direct benefit to the customers that they're serving, and that these changes may also jeopardize some collective bargaining agreements that have already been taking place. I wonder if you'd like to respond to some of the concerns in the unfavorable testimony that's been submitted in the bill.
Yeah, I'll speak to the collective bargaining piece first. I mean, we're already state plans are already covered. So we've already adopted a lot of these restrictions. And so I'm not sure. I mean, I'm not sure that if it's collectively bargained, I'm open to discussion about that. But a lot of these items are already covered. I mean, that's something I actually hadn't seen that. I need to take a look at that particular submission. As far as the consumers, I think when you expand choice and you expand more opportunity for consumers, invariably you're going to get a better product. And I don't know that the concern that I think a lot of people that support this bill have expressed, and it's one of the reasons why I've continued to support it and try to enact it, is that there are concerns about having PBMs that own pharmacies that have their own PBMs that have their own pharmacies. They're going to argue that that's not an issue, and I respect what they have to say, but I think there's no question that when we limit competition, it's not a good thing. So my support for this is just to be sure there's fair competition and transparency.
Okay, that ends this panel, and then I will call Heather Wertz, Tom Wieland, and Kaylee. Is Kaylee here? And you want to take over?
Would you like to go first?
Ladies first.
Let's start.
I think I've been elected to start.
Okay, thank you.
Good afternoon, Madam Chair and members of the Senate Finance Committee. I'm Heather Forsyth, Deputy Director of the Health Education and Advocacy Unit at the Office of the Attorney General, testifying here today in support of Senate Bill. God, I did the same thing. Senate Bill 626. This bill extends important consumer protections in the health insurance market related to the activities of pharmacy benefit managers. While these protections are currently in place for Maryland regulated plans, they're not in place for self-funded plans. But however, recent changes in federal jurisprudence allow the state to regulate PBMs and extend these protections to self-funded plans, such as prohibiting gag clauses, providing consumer choice, and more, as you heard from the prior panel, so I won't repeat that here. In addition to consumer protections, this bill protects independent pharmacies in the state by requiring PBMs to reimburse all pharmacies equally rather than allowing the current practice, which allows a PBM to reimburse a pharmacy less than it would reimburse itself or an affiliate. And keeping independent pharmacies in business is important for consumer choice. And as Senator Reddy said, consumer I've lost my word. Competition. Thank you. Opponents have suggested that if PBMs can't continue their grip over all aspects of pharmaceutical benefits, that providing these benefits will be more complicated and more expensive, but they offer no evidence that this is the case. Rather, the price of prescription drugs to consumers is soaring to unaffordable levels, while PBMs gain greater control and consolidation of the market, and in some cases, overcharging plans by the millions of dollars. Maryland's not alone in trying to regulate these. There's many other states. I'm running out of time to list them, and the feds are looking at this too. We urge a favorable report from the committee for SB 626. Thank you.
Thank you. Is it Tom?
Yes. Hi, my name's Tom Whelan. I own Ritchie Pharmacy. It's in Brooklyn Park, Maryland, and I'm here in support of Senate Bill 626. There's a lot of stuff in this bill, and I have no way can I cover every one of the aspects of it. I want to talk about rebates. So My pharmacy gets rebates, but the difference between what I get in a rebate and what PBMs get is that mine are really quality discounts, quantity discounts. Like if you go to Safeway and you pay $4.57 for a single box of Cheerios, then you go to Costco and you can pay $4.25 and get 2 boxes, so you save some money. The same with my discounts, but they call it rebates. A PBM goes to a manufacturer and says, I'll make the doctors prescribe your drug. Say, for example, and this is the elephant in the pharmacy world right now, are semi-gluten, Ozempic. I'll make them prescribe Ozempic instead of Rybelsus. And you should give me some money for that. You give me a rebate for that. So my store gets rebates, but it has nothing to do with forcing doctors to prescribe or write for a particular drug. Whereas the PBMs will make the insurance companies cover their particular drugs. So basically the PBMs are forcing patients to get a particular drug in a class, regardless of whether it's the best for the patient. For instance, my brother was a pilot and he flew international flights. He would fly to Amsterdam, maybe to Indonesia, to Africa, maybe back to South America. So a refrigerated item is not going to work best for him. But if you're a stay-at-home person and you have to take lots of different pills, maybe Rybelsus would be better for you because it's a once-a-day pill. Who should make that decision? A PBM who's going to get a rebate on a particular drug, regardless of what patient really needs to have? Or maybe the doctor and the patient should decide what drug they should get. I could cover a lot of other subjects, but thank you for your time.
Do we have any questions? It's really nice, good to have a pharmacist here. The whole PBM thing is very difficult sometimes to understand. So is it Dr. Whelan? Would that be correct?
Well, pharmacists today are really BS.
Oh, really? What? Yeah.
Some of us have master's degree and some of us, and my patients all call me Dr. Whelan, but I'm just a pharmacist. I've been doing this for over 40 years. I'm recently turned 70. So I don't know how many more times I'll be up here in front of you guys, but I just hope that somebody does something for independent pharmacies in this state because, well, you give me a second to say, Rite Aid didn't close just because of theft. It's because the PBMs are taking our money. They're taking your money. And you mentioned about who can you go to go get your prescriptions filled? I bet every one of you, if you pull out your wallet and you look at your prescription card, it has CVS on it. Mm-hmm. I thought there was a law against that. Maybe it has Walgreens for somebody else. We need to have freedom to go wherever you want, get your prescriptions filled.
Yeah. Well, I appreciate your work and your testimony. Thank you, Dr. Whelan. That ends this panel. I don't see any other questions. We have 6 unfavorables. Yeah. Bill Kress, Matt Celentano, Heather Cascone, Michael Johansson, Camille Fesh, and Kimberly Robinson. Yeah. Well, Kim, you're definitely signed up on this one. Okay.
Who wants to go first?
I'll let Matt go first or Kim.
No, me?
I'll start. Good afternoon, everyone. Heather Cascone for PCMA again. Happy to be here on requesting an unfavorable report on Senate Bill 626. In August of 2023, the 10th Circuit Court of Appeals unanimously ruled against the state of Oklahoma on a law that sought to regulate self-insured plans and their administration of their pharmacy benefit, or regulate PBMs, known as the PCMA versus Mulready case. The court's decision expounded upon the breadth of ERISA preemption and how the Oklahoma law regulated core self-insured plan benefit designs, an area of exclusive federal concern. While it may sound like this is an issue about PBMs, PBMs are merely agents, third-party administrators of a self-insured plan, of the plan sponsors. State laws that impose burdens on PBMs and any other TPA are ultimately passed through to plan sponsors, in this case, employers, labor union sponsors, governments, and they are increasingly concerned with the risks to their self-insured benefits, as evidenced by the numerous and diverse plan sponsor voices who weighed in with written statements today. Given the importance of unions offering cost-effective benefits for their workers, erosion of ERISA preemption poses an existential threat to organized labor and its cause at its core. If enacted, this bill will send a shockwave of concern to plan sponsors, as it would create a cumbersome, inefficient, and costly patchwork of potentially conflicting state-by-state benefit requirements. The fiscal note was raised earlier, and I just would like to call out that it did in fact indicate a potentially meaningful impact to businesses, one which I am here on behalf of our plan sponsors, PBM plan sponsors, that they have raised this exact concern with us. It's for those reasons we request an unfavorable report. Thank you.
Hi, my name is, for the record, Camille Fesh, here on behalf of PCMA in respectful opposition to this bill. This bill is really about extending state regulation to plans that have never been regulated by the state, self-insured employer plans, as Heather said. This is contrary to the purpose of the federal ERISA law, and it will undermine the plans that are put forth by nonprofits, local government plans, large companies that are headquartered in Maryland, and it will raise costs for the plan sponsors, the employers, and for the patients, their employees. I want to call out the written opposition that you will see. First off, Vicki Leonard from the Building Trades didn't make the sign up, but she's here and wants the Building Trades opposition registered. In addition, you'll see written opposition from MACO, the Maryland Chambers, Laborers International, MCUA, financial advisors who represent employers, and others. These are real entities in Maryland that have functioned under the ERISA law, and they will feel significant financial impacts. And more importantly, the Marylanders that work for them will also feel the significant financial impacts from this bill. And with that, we respectfully urge an unfavorable report. Thank you.
Good afternoon, Madam Chair, members of the committee. Bill Kress here today on behalf of the Laborers International Union of North America in opposition to the bill. The Laborers Union has over 500,000 members. They operate in multiple states. They have an ERISA plan. They are self-funded. The plan is carefully chosen by their members with the use of consultants. They employ a PBM. They receive benefits. They take care of their members. So we're a little bit different from a private insurer. We have a membership and leadership team that goes through these benefits. They're very concerned about impact from state law. The sole purpose of ERISA is to have an insurance plan that's nationally available without state regulation. We're concerned that should you pass a bill that you're going to impact members in not only in Maryland, but throughout the nation. And we respectfully urge an unfavorable report. Thank you.
Madam Chair, members of the Senate Finance Committee, Matt Celentano, for the last time here today on behalf of the League of Life and Health Insurers and AHIP in opposition to Senate Bill 626. I'll try to be as quick as possible. By extending the provisions of the prior PBM law structure to self-insured plans, these proposals will restrict the opportunity for health plans to reduce their prescription drug costs. It's just that simple. This will also come as a surprise to a ton of businesses, as they will most likely have zero clue that these conversations are even happening, and they'll see extreme sticker shock if the bill moves forward. The League and AHIP thinks that the intent of this bill misses where the financial burden of the bill lands, which is businesses trying to provide coverage at affordable levels to their employees, who ultimately bear the burden of this legislation. We ask for an unfavorable report.
Excuse me. Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of the Cigna Group with a frog in her throat. I'm here in respectful opposition to this bill. As you've heard from others, the way that ERISA is set up as a law is to provide uniformity for those large employers who have the financial wherewithal to self-insure the benefit, which means that they are paying the money to pay every claim that comes in for their employees. And in doing so, the federal law allows them to design the benefit plan that they seek to offer to their employees. And most of those plans are using consultants. They're very highly sophisticated purchasers, and they understand what they're building when they choose to do so. PBMs are merely contractors who build what the purchaser requests. If the purchaser wants an open network, we provide an open network. If the purchaser wants a closed network, we provide a closed network. These are decisions that are left to the purchasers. Under the federal law and the Supreme Court decisions in Rutledge and now the pending 10th Court decision in Mulready, there's a limited space where the federal law allows some state interaction with ERISA plans. And Maryland previously went straight to the limit of that after the passage of the Rutledge decision. In the Mulready decision, another state has tested to see where those limits are, and that particular circuit has written one of the strongest ERISA decisions I've seen in a very long time, which it looks like it may be appealed all the way to the Supreme Court, but they were unanimous in their decision. They refused to reconsider it. And they wrote, if anyone wanted something to put you to sleep at night, a very strong opinion about why the further expansion of all of these laws to PBMs does run afoul of ERISA. We are here on behalf of those who purchase services from health plans and from PBMs, health plans to administer, and PBMs who administer the pharmacy benefits for these plans. You've got lots of testimony from the people who are truly affected, which are those employers. With all due respect to the pharmacies who have an interest, it is the employers who are going to be most affected. And for that reason, I urge your unfavorable report.
Senator Reedy.
Thank you, Madam Chair. I'm curious, and maybe I'll ask Matt, what you're representing carriers, of course. What is of the things that this bill would do, which would, basically allowing pharmacists to freely share information with patients, allowing patients to choose where they go to get their medications, fair uniform reimbursement for drugs across pharmacies. Just reading from the fiscal note, I mean, there's like 5 or 6 things, big things here. What in particular do you think would be most difficult for carriers to comply with versus maybe what is less difficult? I mean, you're saying all of these things would be too hard to deal with, or you just comment on that?
I think fundamentally, Senator Reedy, what the bill does is takes away options from the purchasers that are outside of the regulatory structure that has traditionally happened in the past. So self-insured plans don't operate under the oversight of the MIA, and they didn't ask for this. And now all of a sudden you're extending authorities that this General Assembly has given to the commercial market to self-insured plans that don't operate in the same space. The carrier in this instance is just a TPA. Right? We're just administering the benefit that those purchasers make. You're trying to extend provisions that were put on the commercial market into a self-insured space that has a different benefit design that is going to change the way that their drug spend is. They don't get any more benefit out of it. All they get is added cost to their prescription drug design.
And forgive me if this maybe is a sort of a rudimentary question, but what is different from doing this versus the healthcare mandates that we pass in the state that requires all plans to carry?
So those mandates don't apply to self-insured
They
plans.
don't at all.
Yeah.
Thank you, Madam Chair.
Thank you. I have a question. So this bill only applies to self-insured plans?
Correct.
Thank you for clarifying that, Madam Vice Chair.
I guess, Matt, you can answer this, or no, Heather. I'll ask Heather, get you off the hot seat for a minute. What, if this bill passes, what are the ramifications? I mean, you probably have said it and I sort of missed it, but tomorrow it passes and the law goes into effect. What would happen to my ERISA plan?
Thank you for the question. Very quickly, the employer plan sponsor would need to look back to the existing Maryland statute that advises PBM regulation and update their plan to comply with the various provisions of existing law. Currently, they are exempted because of a federal ERISA law. The ERISA law preempts them from having to adhere to that set of Maryland standards today. So for example, ERISA plans enjoy preemption on issues of core plan administration. That is to say, how they design their benefit. Things like what drugs are covered under the plan, how much those drugs will be charged to patients and plan sponsors, in what manner, through what channel they should be directed to fill those prescriptions. Those are core aspects of the plan's administration. And so they would now need to comply with the administrative burden of catching up their plan and also bear the cost as a plan for limiting those cost-saving measures that they currently use.
Okay. Now, my other question is, we, as a state, we're in the ERISA plan, and I can go to any pharmacy I want, can I?
The state plan follows state law, doesn't it? Yeah. The state employee, my understanding, and I'll ask my panel here to keep me honest, but my understanding is the state employee plan here in Maryland currently, while they are self-funded, follows state law as if they were a fully insured plan.
So
By
that means
choice,
I can
by
go with-
choice.
By choice, I can go. That's
Correct,
what I
by
thought,
choice.
because I have a couple different.
They've
pharmacies.
made a decision to follow the law as if they were a fully insured plan.
Okay, all right, thank you.
Sure.
Senator Mounts.
Thank you, Madam Chair. And this is pretty technical stuff. I'm absorbing it and trying to synthesize everything. And the testimony about the ERISA plans, that Supreme Court case in Rutledge, you know, even though it is an ERISA plan, I mean, you're not contesting that the state can't do what's in this bill, right? I mean, that's pretty well, you're not contesting that in your testimony.
Right. So the Rutledge decision focused specifically on a narrow set of features of a pharmacy plan that were related to certain types of cost. And Maryland, in the year after Rutledge passed, actually did update our PBM statute and did make an expansion to ERISA plans for that category of statutes, right? So where the federal law said this is not plan design and not determining those things that a plan decides for itself, this is what my benefit plan is going to look like, but are narrowly focused on costs, we are going to say that a state can apply those provisions to an ERISA plan. And Maryland did. The provisions that we're talking about in this bill are things that I think very clearly can be argued are benefit design. And that is, for instance, the fact that in managed care programs, we have networks of physicians, networks of pharmacies, and that is a benefit plan design. You can choose to buy a plan that says you can go see any doctor you want, any pharmacy you want. It's all open to you, an open access plan. You can buy a network plan that says we're going to, for various reasons of the plan, based on geography, based on costs, based on how they want to structure their benefits, we're going to do a network plan that says we're going to have a preferred or an exclusive network of physicians, of pharmacies, whatever that might be. That is a design plan that the employer, in this case, as the ERISA purchaser, decides for itself. This bill moves into things that I think can be argued. And if you look at what is now the next most significant PBM decision in Mulready, would fit under the umbrella of prohibited ERISA expansion into benefit design. And so when we talk about this bill different than what the state did in its previous expansion, it falls into what we believe the court's current jurisprudence suggests is outside of your jurisdiction to be able to actually do. And when you ask, Madam Chair, what could be the outcome? We know in Mulready, there was litigation that occurred to challenge whether or not that state had gone too far, and the court ultimately told that state they had. It doesn't mean that's impossible here. I think we may wait to see what happens in that decision. But we are saying we believe that this goes a step too far and that it does have real consequences for your large employers who self-insure and have chosen to make Maryland the home of their business.
Right, and you thoroughly explained that, so thank you. And one other quick question about, if this were to go into effect and the private self-funded plans would have to renegotiate, aren't they using the same PBMs as the other providers?
Yes, I mean,
So those already exist, right?
it's not about the PBM. It is only about the employer who now will have their benefit plan disrupted and will now potentially, and I think arguably, if they have chosen to make decisions to do something like a preferred pharmacy network, for example, where that by controlling how many pharmacies are participating, they're controlling their cost, they lose that. And so now it certainly has an impact, and they've got to now revamp all of their benefits. They will have to bear whatever cost implication comes along with that. Right. And so that for them can really be felt as a sea change. It also, to the extent they've got employees in other states, those employees in other states are going to be affected by what Maryland does to them at that point as well. And for businesses who are deciding, where they put their companies, this is not typically, health benefits is not usually a driving factor because ERISA protects them from that. It becomes a factor. for where you decide, when you look at all on balance, what does that mean for you? It becomes a new factor under a new world.
All right, thank you.
See any other questions for this panel? Oh, women.
Can you just repeat that last sentence you said about people coming here to work? Is that what you said?
I think realistically, as businesses, a business who's not headquartered here, right? But when businesses look at where they're going to put their companies, everything's on the table. I think what is interesting is that health benefits has never been one of the things that had to be on the table if you're an ERISA plan. And so as states are making decisions and states are starting to try to regulate in this space for ERISA plans, I think at some point the consultants are going to start having to have that conversation as they help companies assess where they go, because now it's going to be something new you've got to consider where you never had to consider it before. Setting your benefits was exclusively left to you.
Okay, thank you.
All right, thank you again for this panel. I see Mr. Johansson is here.
Just wanted to say hi.
Thank you. We missed you earlier today, Mr. Johansson.
That's what I wanted to say. Not
Our-
ignoring.
Our final testimony is a virtual testimony from Fred Brown, unfavorable.
So thank you, Madam Chair and members of the committee. My name is Fred Brown. I'm the president of the National Labor Alliance of Healthcare Coalitions. We've heard a lot of discussion about how these plans could be undermined with the imposition of this legislation and the consequence of having to apply across state lines. The NLA is a coalition of healthcare purchasing coalitions from across the country with about 6 million covered lives. I'll just mention that many of them are headquartered on the East Coast and have a high percentage in the mid-Atlantic states, including Maryland. As you know, health and welfare benefits offered by unions are key components in attracting high-quality workers and employers to be signatories to their union contracts. Any attempts to undermine these benefits can be an existential threat, as was mentioned a moment ago, to the union's competitiveness. And since the Supreme Court's narrow decision, in our view, of Rutledge, we have seen a systemic attempt across the country to undermine our ERISA-protected health plans, particularly in red states. However, even in the more blue-leaning state like Maryland, we are concerned that the unintended consequence of passing the definition change of purchasers in this bill to apply to self-funded health plans, including our ERISA plans, will undermine ERISA. Currently, Taft-Hartley Health Fund trustees freely make plan design changes to benefit their members, particularly even though they may not fully understand what it's about, what it means, how it benefits them because of ERISA preemption. As a simple reminder, ERISA creates uniformity for union health plans which strive to provide robust health benefits, often across state lines, while struggling to maintain affordability. So the consequence of acting the definition will, in our view, undermine ERISA, and we recommend an unfavorable report. Thank you.
Thank you, Mr. Brown. Do I have any other questions for Mr. Brown from this panel? Thank you for your testimony. That ends the hearing on Senate Bill 626. And it takes us to our last bill of the day, Senate Bill 681, Senator Lamb and Senator Guile.
You want to?
Can I start? Okay. All right, great. Thank you, Madam Chair. Members of the Finance Committee, for the record, Clarence Lamb, Senator District 12, here to present Senate Bill 681, the Transportation and Climate Alignment Act. These slides are in my written testimony as well, if you'd like to reference them later. This bill mandates that MDOT and regional planning entities measure and mitigate increases in climate pollution and vehicle travel caused by planned highway expansion projects that cost over $10 million. Mitigation measures can be tailored to the particular jurisdiction. The bill is prospective and does not apply to projects that are already in the pipeline before July 1st, 2024. Currently, transportation is the largest source of climate pollution in Maryland, and the state is at risk of not meeting its climate goals. MDOT's climate pollution reduction plan indicated that 20% per capita reduction in vehicle miles traveled was necessary by 2050 in order to meet the 2031 targets. New initiatives and more information are needed to hit our climate targets by that goal. SB 681, by requiring impact assessment and mitigation for future highway expansions, will provide us with the forecasting that we need to be able to make good decisions that move us closer towards these goals, while also ensuring that we do it in an equitable way. This chart shows how forecasted vehicle miles traveled levels may push us over our transportation targets, and how an annual per capita VMT, or vehicle miles traveled, reduction of just 0.65% can help us meet our goals. So in conclusion, this bill is an important step in ensuring that Maryland meets the goals set by the Climate Solutions Now Act that was passed a couple of years ago. I'm happy to turn it over to other members of this panel and take questions at the end. Thank you.
Madam Chair, my name is Stuart Schwartz. I'm the Executive Director of the Coalition for Smarter Growth, and we support SB 681. We are a 27-year-old nonprofit working in the DC region with a focus in Montgomery and Prince George's, with some support for groups in Frederick and Charles as well. The Transportation Climate Alignment Act will ensure your transportation investments are aligned with the state's climate change mitigation goals and provide numerous benefits to the state's residents, workers, and communities. Maryland is among the states most threatened by sea level rise and flooding, and has proved itself to be a national leader on climate policy by passing the Climate Solutions Now Act. Transportation, as noted by Senator Lamb, is the #1 source of state greenhouse gas emissions, accounting for about 35% of climate warming pollution. And rapidly tackling climate emissions is key to meeting the state's goals for reducing emissions by 60% by 2031 and reaching net zero by 2045. But it would also advance equity and accessibility and make smart use of limited public dollars while reducing climate pollution. It provides a toolkit. The bill provides a toolkit to evaluate highway projects, and if needed, make improvements to them by giving communities more options to connect residents to jobs and services while providing accountability on the state's climate goals. Maryland's climate pollution reduction plan estimates the state must invest $1 billion per year to meet climate targets. For that reason, we must ensure our transportation investments support that goal rather than undermine those other investments. There are investments in terms of providing transportation options, increasing safety, and saving families money. The TCA will encourage the linking of jobs, housing, and services and infrastructure investments to provide more compact, attractive, and competitive communities for doing business, creating a home. I think this approach has been key to attracting and retaining Fortune 500 firms in Maryland, including Marriott and Choice Hotels, not to mention the FBI. These have gone to transit-oriented locations, walkable, accessible places that lower the combined cost of housing and transportation, lower greenhouse gas emissions, and save money on transportation overall. And so, in short, Prince George's, Montgomery, and other jurisdictions will benefit from this economically, and we urge a favorable report. Thank you.
Thank you. Who's next?
Good afternoon, Madam Chair. Josh Tolkien on behalf of the Maryland chapter of the Sierra Club. It's a pleasure to be back in the Finance Committee. I'll make my comments brief. I'm not going to try to convince this body that climate change is important and urgent. You've passed the Climate Solutions Now Act. You made that decision. Nor do I want to convince you that it's important to reduce our vehicle miles traveled. The Department of Transportation has established that as a critical goal. What I'm here to encourage you to do is to consider that we need additional structures and decision-making changes to achieve this type of goal. That the way that MDOT has been making decisions historically in collaboration with the MPOs does not give them the information or pose the important and necessary questions that we need to make the decisions to reach our climate pollution reduction. Recently, we have seen that the proposed CTP proposed significant cuts. What none of you heard was what the greenhouse gas emission result of those proposed cuts would be, nor in the outer years. That's not supplying either the state or the decision makers with that information that they need. On the flip side, Governor Moore has proposed $90 million for greenhouse gas reduction. 23 million of that is going into electric vehicle charging infrastructure and 16 million to electric school buses. It's critical that we make sure that we're not spending tens of millions of dollars reducing pollution on one hand, and then not asking the question, what will be the climate impacts of perhaps the largest funding source that Maryland has that's going to determine our climate future, which is the Consolidated Transportation Plan. The goal here is to not stop highway expansion. The goal is to make sure that Maryland is creating an accountability process. So when it proposes expansion, it's considering how to achieve those same goals on climate and vehicle miles traveled at the same time. Thank you very much.
Thank you. Josh, who's next?
Madam Chair, committee members, good afternoon. My name is Miguel Moravic, and I work with the Rocky Mountain Institute. If you haven't heard of RMI, we were founded 40 years ago to answer one big question. If you make our energy system more efficient, what will the benefits be in terms of cost savings to consumers and economic activity? Today, 40 years later, we're happy to ask that same question for Maryland's transportation system. If you give Marylanders more efficient, affordable, and clean transportation choices, what would the benefits be? And Senator Lime, could you advance the slide, please? So I'm here today to share that the benefits of achieving MDOT's vehicle miles traveled target would be tremendous. By replacing just 1 in 5 car trips in Maryland with some other more affordable or efficient mode, you would save each Maryland household over $3,000 per year on average over the next 25 years due to reduced fuel costs, maintenance costs, and avoided depreciation. Next slide, please. And those are just the consumer savings. There are massive health benefits, safety benefits from avoided car crashes, and yes, of course, the climate benefits would be very large. By achieving MDOT's target, giving them the tools to achieve it, you would reduce 55 million metric tons of carbon pollution. That is the same as turning off the annual emissions of 138 natural gas-fired plants here in Maryland. Next slide. I know these numbers are really big, so don't take it from me, take it from the state of Colorado. We use their methodology to come up with our numbers, and they found that Coloradans would save a massive $40 billion of net benefit by 2050 under a similar policy. Next slide. I'll just conclude by saying, Colorado achieved this by prioritizing efficient transportation modes using a system-wide approach. Today, Maryland decision makers have the same opportunity to give their state agency the tools they need to hit the climate targets that they admit they're short of. I thank you for your time, and I will stand for questions.
Last person.
Good afternoon, Chair, members of the committee. My name is Benjamin Lin. I am with the Amalgamated Transit Union ATU Local 689. Thank you for the opportunity to provide testimony. We represent about 15,000 members and active retirees, frontline workers in the transit area throughout the greater DC area, including Southern Maryland. We know that, we know that transportation is a primary source of climate pollution in Maryland. And unfortunately, that climate pollution affects our members and the riding public, especially working class people and those from marginalized communities. We are supportive of the bill in front of you today because of the encouragement it includes for mitigation options for improving and expanding public transportation, creating bike infrastructure, pedestrian infrastructure, and other smart growth strategies. We support the legislation because of the inclusion of the Maryland Climate Pollution Reduction Plan's findings. 20% per capita reduction in VMT is by 2050 is necessary for meeting the state's climate goals. Transit workers were frontline workers during the pandemic, and they are, standing up every day, working long hours to help the riding public. And we believe that this bill will help support their efforts and protect the health, reduce traffic congestion, and help our strained transportation dollars be used in the most effective way. Thank you again for the opportunity to provide testimony, and be happy to answer any questions.
Thank you. Do I have any questions for this panel? I don't see any questions. Thank you. Oh, I'm sorry, Senator Mounts.
Yeah, I just looked at the bill pretty quickly. Why are, this is the Department of Transportation that's doing the study, correct? Right?
Yeah.
Or I'm sorry, so the sponsor. So and Mako and MML are not represented in that study at all, correct?
I don't believe they're represented in that study, but we're open to including them.
Just want to verify that.
Yeah.
Thank you.
Senator Ellis.
Yeah, thank you, Madam Chair. And I'm trying to figure out, Senator Lamb, basically, what does this bill do? As far as, is it targeted like a project in mind to really, or there's I think about the talk about the Beltway expansion in Montgomery County, a project like that. I'm sorry, Senator Hayes.
Oh.
Okay.
Senator Lamb, may I?
I'm sorry.
Yeah, good.
Thank you, Senator Ellis. At its core, what the bill requires is that for projects over a certain size, the state evaluate the greenhouse gas pollution of them. And if that project, let's say it could be the Beltway expansion, it could be a future expansion we don't know about, results in an increase in pollution, just note, while we're trying to decrease pollution, then it would require that MDOT come up with a mitigation strategy. So essentially, whenever we have a large project that's increasing pollution, it ensures the state has a parallel plan to decrease pollution, and the same thing for vehicle miles traveled. So it's not stopping those projects. It is simply saying the state has a goal. And if those projects are going to increase the pollution, when our goal as a state is to decrease pollution, we need a mitigation strategy. Lots of similar places where we have similar mitigation strategies. It would be on a project by project basis.
Yeah, okay. Yeah, got it. Thanks.
And the Southern Maryland Light Rail, for example, could be the type of project that was considered at the large scale to create a larger mitigation for if there was a similarly large project that would result in pollution.
Yeah, okay. Yeah, thanks. Appreciate that. Okay, thank you.
Thank you very much.
Would you like to go first? Good afternoon, Madam Chair and committee. I'm Margaret Fulcher with the Maryland Transportation, Central Maryland Transportation Alliance. And I'm here, hopefully that funding will be available for paratransit. We are the forgotten class. Many of the vehicles are aging out and will need to be replaced, hopefully with the electric vehicles. Certainly will reduce greenhouse gases. And the other issue that I'd like to talk about is our sidewalks. In the city, if you live in the city, maybe you're lucky. You're in a neighborhood that doesn't have a problem with the up and down hills of the sidewalk. Those of us with disabilities have great problems with that. If you have a wheelchair, walker, or cane, now you will notice in the city they were in the bike lanes, because that's the only smooth surface other than the streets themselves to walk on. So we really do need replacement of sidewalks in many neighborhoods in the city. And I hope transportation will be available for both paratransit and sidewalk replacements. Thank you.
Thank you. Who's next?
Sure.
Hi, my name is Alexander Smith Burden. I'm a Morgan State University freshman. I live in West Baltimore and commute to Morgan State University every day. Before that, I went to Baltimore Polytechnic and used public transit that way. My commute is an hour and a half, 7 miles within the city. And that is on a good day, getting to my school. On the way back, if I take the green and then the gold, oftentimes I will have 1 or 2 buses pass me because they're completely full. And when I am able to get on a bus during those hours on the gold line, those buses are completely packed. And not only are they completely packed, but everyone in that bus is darker than me. This isn't just like an issue about climate, it's also a racial issue. And it has been in the city for a long time. As far as transit investment goes, we've been fighting for a while. We've been fighting since the highway to nowhere for a rapid rail line. And that eventually ended up becoming the red line. And we saw the investment go to highway expansion without really seeing a lot of investment in the city. The investment that we did get was to updating the already old and outdated system, giving us the bare minimum. And since then, our job access from 2015 has declined from 11% to 8.5% accessibility. And that is to the accessibility of jobs around us within a 60-minute drive. Another issue I want to talk on is students. There are students who spend 4 hours a day on public transit trying to get to their high schools. That means that they don't have extra time for extracurriculars. And that also means that they're getting home at late times when oftentimes they're not in safe neighborhoods. You end up having to pick up calls of people who you care about just to make sure that they can get home safely because they're being followed. Thank you.
I guess Casey, thank you.
Thank you. I'm Casey Hunter, the Program and Policy Coordinator for the League of Women Voters of Maryland, here in support of the Transportation and Climate Alignment Act. As you've heard from members of this panel and the one prior, reducing climate pollution isn't only about protecting our environment. It's also about protecting and improving the quality of life in our communities. Our health outcomes and socioeconomic opportunities are strongly influenced by factors in our communities that oftentimes go beyond our control. Access to safe, reliable, and affordable transportation options is one of these key factors. The TCA would work to improve health outcomes and socioeconomic opportunities for all Marylanders by establishing a key evaluation criteria for prioritizing transportation projects in Maryland. When spending the state's scarce transportation dollars, we must prioritize spending on projects that work towards Maryland's goals to reduce climate pollution and improve mobility. When we invest in expanding transportation options, we're connecting our communities, and this opens up new housing options and job opportunities for Marylanders. It also connects them with access to amenities and services like healthcare and education. And we're not just talking about investing in metropolitan areas. The mitigation options in this bill can benefit more rural communities as well by expanding broadband access and, expanding the ability to work remotely. It's also investing in bike and pedestrian infrastructure. The TCA particularly benefits overburdened and underserved communities who historically lack access to these opportunities and are disproportionately burdened by high transportation costs. As Miguel Moravec from RMI mentioned, reducing vehicle travel by 20% per capita would save the average Maryland household more than $3,000 annually. This puts money back into the pockets of Marylanders that can go towards meeting basic human needs and even stimulating local economic growth. The TCA not only provides a roadmap for achieving Maryland's climate goals, but brings state law in line with its established values. We urge a favorable report.
Thank you. Doug, before we go to you, since you're favorable with amendment, Senator McCray has a question.
Thank you, Madam Chair. And I believe it's Alexander. I just wanted to lean in and just say first, best of luck on matriculating through Morgan. But more importantly, amplifying the voices of those young folks that don't always have a voice. That is the experience of a person that's dealing with a failed MTA system, a failed public transit system at this moment, thinking about the breakdowns, thinking about the bus not coming, thinking about the bus coming late and what are the implications of that. And I always say, you hit it right on the nose in reference to, unfortunately, if you live in the wrong zip code, It is tough to break the generational cycle of poverty, and transportation has a large role in that component. But more importantly, I'm very sympathetic to the adults, but imagine not investing in our young scholars. Imagine if you are just trying to get to school on time and how that impacts your education and how we're setting them up from failure for that standpoint. So I'm gonna stop right there, Madam Chair, but I just wanted to lean in. Thank you for just amplifying the voice of those folks that don't always have a voice.
Thank you, Senator. Senator Ellis.
Okay, yeah, I just want, thank you, Madam Chair. I just want to say thank you. I appreciate all you being here. And I appreciate Senator Lamb, this bill, because for my first day in Annapolis, the first bill I put in was to end the worst commute in the nation. And Josh talked about that. And I've got a lot of support from you all to do that. And we have a ribbon cutting coming up in the spring for Southern Maryland Rapid Transit. Work with, and so it's possible. You all need to keep fighting for transportation that's great for your citizens to get to work, transportation alternatives that will cut the pollution in the air, which kills more Black and brown children with asthma than any other group. And so I thank you all for being here. I'm thanking you for waiting all day to show up and to share your testimony. Isn't that so, Madam Chair?
Thank you, Senator Ellis. And it is. Okay, I have no other questions for the favorable panel. And Doug, favor with amendment. Thank you.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Doug Myers. I'm the Maryland Senior Scientist for Chesapeake Bay Foundation, echoing all of the testimony you've heard previous in the first two panels. Just wanted to add one thing. Greenhouse gases are also bay pollutants. And so Chesapeake Bay Foundation increasingly engages in positive legislation where vehicle miles traveled and greenhouse gases can be reduced significantly, because all of those nitrous oxides that come with burning fossil fuels eventually end up in the bay as a pollutant. In addition to that, our amendment is very friendly, and I think it's almost maybe not necessary. It's a technicality as we're reading section 2-905A about the requirement to mitigate greenhouse gases and vehicle miles traveled, to be able to take the list of items in B1 below that, which are part of the plan for mitigation, and be able to quantify those benefits. Because you could read this as, well, if I build a crosswalk, that's on the list of things that could partially mitigate. If without having the currency of vehicle miles traveled or greenhouse gas reductions for each of those elements of a mitigation plan, we feel like it might be a little too easy to mitigate without quantifying those at the same yardstick that you're using to quantify the greenhouse gas emissions and vehicle miles traveled from the project. And that's the only amendment we would offer. Thank you.
Thank you very much. Do I have any questions for Doug Myers? No questions. That ends the hearing. Thank you very much. That ends the hearing on Senate Bill 686. It ends our hearings for today. Committee, do not go far. We're going to be voting in just a few minutes. Thank you.